This is talk number 52 and topic for today's approach to liver biopsy part 2. This is a slide seminar. The chairperson for today's seminar is Dr. Padmawati. She is professor and head Department of Pathology, MMC, Chennai. The presenter for today's slide seminar is Dr. Siddharth Dattagupta. He is Emeritus Professor NAMS and Adjunct Professor Department of Pathology, St. John's Medical College, Mangaluru. And these are the participants for today's seminar. And participants, please introduce yourself. Dr. Jalise.
I'm Dr. Jalise Murtaza from Sher-e-Kashmir Institute of Medical Sciences. I'm a third year PG resident.
Dr. Tanvi.
Dr. Tanvi from Lana Azad Medical College, New Delhi, PG 30. Hi, can you hear
Dr.
me?
Jyotika. Yeah.
Jyotika from MLB Medical College, Jhansi.
Dr.
I'm
Bhavya.
Dr. Bhavya. Yeah, I'm Dr. Bhavya. I'm from St. John's Medical College, third year PG.
Dr. Yogita. Has she joined? Dr. Yogita. Dr. Rahul.
Myself, Dr. Rahul Gupta from SGPG IMS, Lucknow, second year PG.
Dr. Ranjita.
Good evening, everyone. I'm Dr. Ranjita, PG Year 2, KMC, Mangalore.
Dr. Therese.
Good evening, everyone. I'm pursuing my DNB third year in Apollo Hospitals in Chennai.
Dr. Aska. I think she has not joined. So these will be the participants, and the moderators for today's slide seminar are myself, Dr. Sonal. I'm Associate Professor in Gandhi Medical College, Bhopal, and Dr. Urvi Parekh, Assistant Professor in BJMC, Ahmedabad. The webinar hosts are Dr. Anita Borges ma'am and Dr. Sumit Kushal sir. These are few reminders. Please do not send requests for annotation to the presenters. These are few disclaimers. These are few more. And these are the upcoming talks. The next talk will be on basics of coagulation, coagulation cascade, current concepts by Dr. Tulsi. She's Professor CMC Vellore on 16th April. And on 18th April, there will be next slide seminar on approach to a case of bleeding disorder and DIC by Dr. Narendra. He's Professor PGI Chandigarh. So now let's start. Over to you, sir.
Thank you. I'll just share my slide.
Yes, sir. I'll stop sharing.
Dr. Aska has joined us. Sir.
Okay, he has joined.
Please join.
Can you? Sorry, you can't say no?
No, sir.
No, sir.
Right.
I guess I'll have to share the screen, is it?
Please.
Sir.
Now can you see?
Yes, sir.
Yes,
Yeah?
sir.
Yes, sir. Yes, yes.
Good evening, everybody. So, Eid Mubarak to all of you and greetings for the entire season where I think belated Ugadi and Gudi Padwa and then in advance and of course Bihu and in advance for the other festivals and New Year's which are coming up in the next few days, including Ram Navami, Baisakhi, and Tamil New Year's and other festivals. Well, sorry to pull you all out on a holiday, and we'll continue where we left last time. I'll quickly go through what we did last time and we'll continue. And I must thank my former colleagues, Dr. Madhu and Dr. Rajni, for helping me out in getting some slides since I've retired from AIMS quite some time back. Okay, so now let's go with the slides. These are the disclaimers. It's meant for teaching and compiled from my own from our own material or acknowledged, and there's no financial interest or conflict of interest. So now the last time we had some wonderful PGs who joined us, and they did pretty well. We had 4 second year and 3 third year residents. And this time we have students from all over the country, from Mangalore. We have Ranjita, then from SGPJ, Rahul, and then from Hamdard, we have Aska, who has joined, I think, just now. From St. John's, we have Bhavya. From Sherry Kashmir, we have Jalis. Himangini couldn't join, I think. And Jyotika is there from Jhansi. And then from Maulana Azad, we have Tanvi. From Apollo Hospitals, there is, I think Yogita also couldn't join. So we have a wonderful batch of 8 people with us today, and we'll continue with that. Now you see how this was planned was, this was in about 4 steps. You see, on the first we were warming up and we did the basics of liver biopsy, certain technical aspects, normal and familiarity with how you view a slide. The second thing that we did on that day actually was liver injury, sublethal injury, necrosis, identifying, because these are the common things that we do. And we get some examples, and one case we did a broad outline of reporting, autoimmune hepatitis. I'll show all of them just briefly. So now is the time to run. And so we will do certain common non-neoplastic diseases. We'll see special stains in immunohistochemistry. We'll recollect some of the hepatitis. The reason why, although you may get less of chronic hepatitis slides to view now, it's best if you want to see a liver biopsy and learn from it, pull out a slide of chronic hepatitis and start with it. You'll do wonderfully. If you have autopsies, well and good. If you don't have, this is the best thing. So that's why we'll see different facets of liver injury in that, because we are concentrating on non-neoplastic. Finally, we'll consolidate the learning. I'll show some quick slides, which the third years will tell. And then we'll stop here. The rest is left to you. You have to learn lifelong, gain experience, and then of course you'll become an expert better than any one of us who are here today, because you are bright people and there's no harm. So that's how we did. So the first 2 bright lights are the ones that we completed. The next 2 will complete now. So we saw the reasons why we do a liver biopsy. That's been discussed. And now it's mainly to determine the severity of liver damage and prognosticate. We saw there'll be needle biopsies, wedge biopsies, and in wedge biopsy, avoid the superficial part. One, because just from the superficial region, you have bands going down, they form nodules. So superficial biopsy is bound to mistake that for fibrosis, and you generally get a lot of collapse and inflammation just below the capsule. Why it happens, nobody knows, but that's what is the observation. And please remember, you're only sampling a liver. That's 1/50,000th of the entire liver. But does it make a difference? Of course it does. See, geologists, they see even 1/1,000,000th of the earth and they'll tell you what is inside. So we are doing the same thing. So see the thickness, whatever your institution you're comfortable with. If it's little thick, it's fine, but you must not overdiagnose inflammation. Okay, so it must be technically proper, and then see the slide, and you'll find that certain diseases, they affect the lobule more. Certain diseases affect the portal tract more. And certain diseases are diffuse, certain are patchy. So acute hepatitis affects mainly the lobule. Acute hepatitis is a diffuse disease. Every lobule is similar. So small biopsy is enough. But in chronic hepatitis, it's patchy, affecting mainly the portal tract. So you see, if you see a biopsy, this will show, I'll show you the slide, I think. Yeah, this shows that the portal tracts have got moderate to severe inflammation. In this, it's not there. But actually, these are the same two portions of the same needle biopsy. So it is just sampling that's important. So it's always clinico-pathological. Same thing about fibrosis. We may underdiagnose or overdiagnose fibrosis. So for a chronic liver disease, you need 20 millimeter length and include as many portal tracts, definitely more than 6, ideally more than 10. If it is less than between 10 and 20 millimeters and few portal tracts, remember this for chronic liver disease, not for acute, then it's compromised. Inadequate is less than 10 millimeters or 1 centimeter and less than 6 portal tracts. Now, what is the size of the needle you have to use? Best is, tell your clinician, 16 gauge needle at least, because the distance between a central vein and a portal tract is about 0.8 millimeters. So you must have a needle that is wider than 0.8, and the 16 gauge needle is 1.6. You get things which are about a little more than, a little less than 1.6, and by the time you fix it, there is a shrinkage of about 10 to 20%. So you will at least get in the breath, if there is any portal tract and the central vein, you'll be able to see it. Lengthwise, of course, you'll be able to see. It doesn't matter even if the biopsy is thin. So theoretically, this is why a 16 gauge needle is recommended. Okay, that's because of the distance, right? But for certain things like amyloidosis, even a small biopsy is enough. You don't have to crack your head on that. We saw a normal liver biopsy. The dilated area without anything is the central vein, and this area, which will be lightly stained, will have certain open structures, will be the portal tract. So central vein has very little, fibrous tissue around it, and is lined by endothelial cells. And this is the only place where you'll find radiating hepatocytes in the centrizonal area. Elsewhere, it's all irregular. Like portal tract, it's called portal triad because it has 3 structures. Artery is the bile duct, and the largest structure is the vein. And from the artery, 3 diameters very near, within that you draw a circle, you will definitely find a bile duct because both of them grow together, right? And the diameter of the bile duct and the artery is almost the same. So this is how you identify. It's very important. Every portal tract, look for all the 3 structures. In all portal tracts, you may not find all 3. But important is, for example, if you see 10 portal tracts, you must find bile ducts in at least 8 of them, these profiles, if there is an artery accompanying it. Okay. And we saw how you describe periportal, midzonal, and centrizonal, approximately 1/3, 1/3, 1/3. So this is the Kernian's lobules, the earlier terminology. It's quite okay. But the Rappaport's concept, in this, the terminal hepatic venule or the central vein is this central structure. But in Rappaport's concept, because the blood flows from the portal tract, arterial as well as portal venous, flows from the portal tract to the centrizonal, he divided the area into 3 very like areas, all touching the portal tract. So this is zone 1, then this is zone 2 and zone 3, roughly corresponding to periportal, midzonal, centrizonal. You can describe either using this terminology or this terminology. But currently most people prefer zone 1, 2 and 3, right? So that's, then we saw in human beings, we don't have a fine fibrous tissue separating globules. They are all continuous. So how do you, the last layer of hepatocytes, which is, it forms the imaginary boundary between the mesenchyme and the parenchyme. Okay, so there's a point. Oh yeah, I'll use that. Okay, between the mesenchyme and the parenchyme, this is the limiting plate. Okay, so look, this is the limiting plate. Okay, what is this? There's some notice, Sonal, saying that share computer audio or something like that. I have to ignore that, I guess.
Yes, sir.
Okay, thank you. So now you see, in a normal biopsy, it's not necessary that you get all the three structures, the portal tracts. You can get portal DADs. In some portal veins will be absent, some hepatic artery, and bile ducts also may be absent. But remember, in 10 portal tracts with arteries, bile ducts normally are 7 or 8 at least, right? If it is less than 5, then there is paucity. We'll come to that. So this is how the normal architecture looks like. They're all irregular. You see, it's not straight as except near the central vein. Okay, they are not straight arranged like that. See, so this is only in drawings. Okay, it's all irregular. Please note, you will never find bile. Normally, if you find bile, it is abnormal. And the bile canaliculi forms by two adjacent hepatocytes. One side is the blood is flowing. That is the sinusoid, right? The sinusoid, the difference we saw between capillary and sinusoid is, in the sinusoid, there is no basement membrane. The endothelial cells form certain gaps, so they allow easy access through these gaps. So that is what a sinusoid is. And in the liver, in the sinusoid, between this endothelial cells and the hepatocytes, you have the space of Disse, where you have Kupffer cells, you have the Ito cells or fat storing cells, and so on. So in cirrhosis, this area gets fibrosed. It's very important. This area gets fibrosed, so there is no flow of blood into the hepatocytes, and there are problems. Will not go into that. And adjacent hepatocytes, they form a cup-like area, and so that forms the canaliculi. You can't see it normally. Never. You will never be able to see it. Only when there is cholestasis, some cause, you will get it. Okay. Then we saw this slide. This is the portal tract, and there are certain cells here. And what these cells here, we found the megakaryocytes, and some of these are erythroid cells and neutrophils. All look at this inky blue with little pink cytoplasm. Look, these things. And then, of course, there's some iron pigment also. This is typical of a baby's or neonatal liver. So we saw that last time, right? So that we saw. And we know that there's some hemopoiesis. We asked you, till when do you get this hemopoiesis? And many of you answered. The answer is till about 5-6 weeks after birth. Then, of course, the other organs, usually the bone marrow takes up. Saw the difference between EMH and CML. So CD34, 117, and TDT are positive in the neoplastic ones, right? And usually in benign one, there's multi-lineage proliferation, all kinds of cells. Neoplastic, you may get unilineage, but but in certain MDS and CML, you do often see multi-lineage things. Okay, so then we asked you to view this slide. There, it all looks poorly preserved, So anyway, this was an autopsy slide. You have to identify the central vein and portal tract. And then this was mainly shown to tell you that, look, this is the capillary, this is the space of decay, and these are the hepatocytes. Okay. So just to show you that in autopsy specimens, the space of decay widens out, right? This is a fixation artifact. Then we found this case where we found some surviving hepatocytes, portal tracts all close to each other, and these areas look pink. Is it fibrosis or something else? That was what the thing is. These are all surviving hepatocytes. And then we went into higher part. It doesn't look like fibrosis. Then you identify that these are sinusoids which are compressed, right? This is an apoptotic hepatocyte here. This is also sinusoid. So this means that these have all become necrotic and collapsed. And these are the surviving hepatocytes. And they're all damaged. You see this? The cytoplasmic vacuolation. And these small things, if you see under high power, there'll be a green dot. That's all intrahepatic cholestasis. And so you see, this is another area. These are the remnant sinusoids. And these are the necrotic cells. So this is an area of necrosis, you see. And in the, one has to be careful while interpreting the reticulin stain in these cases. They look, because they are actually collapsed. It's not fibrous tissue. Fibrous tissue are linear and long, but it's nothing. You see, it's as if this area is collapsed. It's like a wire mesh that's come together, you know. So that's how it is. And meson this blue staining is not there here, right? So any other special stain you can do is, if you're in doubt, do an Orsine stain. Stains elastic tissue. Elastic tissue is normally present only in the portal tract. If there is fibrosis, elastin is, after reticulin, you get elastin, you know. So elastic tissue will be deposited if there is fibrosis. That's one of the best stains to identify early fibrosis. So you see, this is the portal tract. This is how it will look in a cirrhosis. So this is not cirrhosis, although it looked under low power like that. So these are all necrotic areas. So this confirms it's a bridging necrosis. What is bridging necrosis? In this, the difference between that and this is there is ballooning change here. Bridging necrosis is between one vascular tree and another. So you have two vascular trees, portal to central, or it could be portal to portal or central to central. Worse prognosis is seen when it is portal to central, because all the blood gets shunted into the systemic circulation without passing through the liver for purposes of detoxification, metabolism, and so on and so forth. So then we saw what are the types of necrosis. It could be a few cells, that's a spotty necrosis, a group of cells, confluent necrosis. Now, when the confluent necrosis is large, it could affect the entire lobule when it is called panlobular, or it could affect one vascular tree to another when it's called bridging. And then this is piecemeal necrosis or destruction of the limiting plate. So these are the types of necrosis we saw last time. You can do special stains, which I told you. See, it may look like cirrhosis, but it's actually bridging necrosis, right? So that's the pitfall. Then we saw hepatitis, acute and chronic. It's mainly 6 months. Why 6 months? Because in 1960s, they have done plenty of biopsies on acute hepatitis, and a group of pathologists, right? They identified that all these changes of acute hepatitis disappear in 6 months' time. Little did they know that in future they are not going to do biopsies for acute hepatitis. It's not done now. So, but anyway, that stuck, and even now we use this 6 months for chronic hepatitis. And acute hepatitis has different things. Acute hepatic failure, if there is encephalopathy within 4 weeks of the onset of illness. Between 4 weeks and 6 months, if there is encephalopathy or liver failure, it's called subacute hepatic failure. Even this acute has been further classified into hyperacute and acute. Hyperacute is very short period. And interestingly, those hyperacute ones can survive, in fact. So, this is important because when they are going to have a quota for transplants, you want to make a list who is likely to get the transplant first. So all these things are important. How long the patient is likely to survive? Can he wait for another person's liver because he X or Y needs it early? So these things are important in acute liver failure. And of course, 99% will have conventional acute hepatitis. Most of us would have had one bout looking like this. Chronic hepatitis problem is, can any of the second year tell me what is chronic inflammation? Anyone? I won't call names, but anyone? Ranjita, year first or second year? Second is, what is chronic inflammation, Ranjita?
It 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 prolongs for several months or years,
Several.
the inflammation.
Okay, anybody else is second year? Anand? Sorry, Rahul.
Uh, One is the duration, sir, and one is the presence of chronic inflammatory infiltrate like lymphocytes and plasma cells.
Okay. Aska, your second year?
So third year.
Third year. Who is second year now? Who else is there? Tanvi is also third year, no?
Yes, sir.
Jalis, Tanvi, Aska, Teres, and they're all third year. Okay, Bhavya is also third year. Okay, now tell me, Jalis, what is your idea of chronic inflammation?
So mostly the cells, the lymphocytes are predominant in the.
Okay. Bhavya?
Seems a long-term inflammation.
Long duration cells. There is also same thing?
So I think the body is not able to remove whatever the etiologic factor, like whatever it could be some microorganism or it could be some ongoing insult which is like causing
So
that
then you
inflammation.
call it chronic inflammation. Okay. You said cells, no? So you meant mononuclear cells.
Yes,
like
mononuclear
lymphocytes.
cells.
In typhoid, what do you get? Typhoid fever, it's mononuclear or polymorph?
Polymorphs.
Is it true? In typhoid fever? What do the others feel? In typhoid fever, what do you get mainly? Okay, in viral
Can be a
infections,
mix.
acute, what do you get?
So if there is a secondary bacterial infection, then it could be
No. Pure viral.
the initial
Mixed
stage could be
inflammation.
neutrophilic, sir. And then
Viral, mostly lymphocytic infiltration will be there.
Yeah, because viruses are killed through NK cells or T cells or other things, no? And they enhance apoptosis. That's the way they killed. Okay, anyway. Suppose so if there is polymorphs, it is acute. In chronic osteomyelitis, suppose it's staph osteomyelitis, what cells do you get? Lymphocytes or polymorphs? Anyone? Yeah? Okay, anyway, you are likely to get neutrophils because that's staph, no? The reaction to staph is neutrophils, although it lingers on for a long time. So there are a lot of exceptions. The actual definition of chronic hepatitis is when inflammation and healing goes side by side. In acute hepatitis, the healing occurs after it's resolved, after acute inflammation. It's not during the process of inflammation. Whereas in chronic, the definition is when inflammation and repair go side by side. So in all chronic inflammation, if the organ is, there are no labile cells like endometrium and this and that, you're likely to get a lot of fibrosis. So for example, if it is muscle, you will definitely get. So in the intestine, if just the mucosa sloughs off, nothing happens. It'll restore itself to normal. The moment it goes into the muscularis mucosae, you're bound to get fibrosis because the muscle cannot heal. No, it doesn't multiply. They're permanent cells, muscle, brain, etc. Brain you cannot replace. Heart, never. You'll never get back the normal muscle. There'll be a scar. So in chronic hepatitis, it's chronic inflammation and fibrosis. That's what happens in the liver. So you get cirrhosis and fibrosis. So that's the problem in chronic hepatitis. So it's not only the inflammation, it's the fibrosis that's going to cause problems. And then of course, end stage of cirrhosis, regeneration, and then you get hepatocellular carcinoma. Okay. So these are the changes: ballooning, cholestasis. These are changes of acute inflammation. Necrosis, you may get fat, and then the end result of inflammation and of necrosis of hepatocytes is that they have some pigment inside. That's the ceroid pigment. It goes out. The ceroid pigment is taken up by the Kupffer cells and other macrophages, and they carry them to the portal tract. You do a diastase pass stain, you'll be able to stain them. So in a recovery phase of hepatitis, where everything else might look normal, you will find these telltale signs. If you do a diastase pass stain, that the ceroid pigment has been taken up, right? And you please note, spotty necrosis, sometimes you'll not find a necrotic hepatocyte, you'll find only lymphocytes. The reason is most of the hepatitis that we are dealing with during biopsies are viral in nature. Sometimes, of course, drug induced and others are there. So, because the virus damages by lymphocytes, T lymphocytes, so you will just find the lymphocytes there and the hepatocyte is not there. So that's how you identify it. Now, how you identify drug-induced hepatitis, sometimes severe necrosis, they usually, whenever the margins are sharp like this, think of drug-induced or toxic hepatitis, right? So this is in acute hepatitis, it's mainly lobular changes. And in acute viral, it's mainly around the central vein. And all central veins equally affected, centrozonal areas or zone 3, right? In the case, then we saw this case, you see, sometimes what is a ballooned hepatocyte? It's about 1.5 times larger than normal hepatocyte. And why is it ballooned? Because the sodium pump is damaged. It's a hydropic change. In children, and usually in some adults, mainly in children, you get trinucleate forms inside the hepatocytes, and in these large balloon cells, and they are called giant cells. So this is typical of neonatal hepatitis, where you get giant cells. Okay, so we saw those cases. There's cholestasis also. You're finding this green cholestasis. There's a giant cell, 1, 2, 3, 4 nuclei, so on and so forth. Right? And look at the bile ducts also. Right? So we saw this. Then we went to this case in detail, a female with race transaminases. And in this, even in LOPA, the seat of action is mainly around the portal tract. This is typical of either biliary disease or of a chronic hepatitis process. Whenever you see that the inflammation is mainly there, you compare that with the acute hepatitis which we saw earlier, you will see it's very easy. You see this in acute hepatitis is almost centrizonal, it's pale here. Portal tract, hardly any inflammation. The only exception is in acute hepatitis A, you can get a lot of plasma cells and portal inflammation. Remember that. Some acute hepatitis drug induced you can get eosinophils also in the portal tract, and they look little prominent, but it's mainly lobular. So you see in this part, and then of course you also can make out fat. You saw this case, and then we saw under higher power, we saw that there were a lot of plasma cells, and there are lymphocytes. Whenever you see a lot of plasma cells, naturally you think of an autoimmune process. Saw the bile ducts, whether they are damaged or not. Nothing much here, right? This is a bile duct that has mishappened, but you have to see them, whether they are affected. There may be a eosinophil here. And you have lymphocytes and plasma cells in the portal tract, and they're spilling over. So there's some piecemeal necrosis. And what is even more these clusters of hepatocytes. These are mainly in the periportal area. You can get elsewhere also. These clusters are called hepatitic rosettes. When you see rosettes or you see plasma cells of chronic hepatitis, think of autoimmune. Then you have to keep searching for this diastase pass, which will show, which brings this out better. And there was fibrosis. Okay, so autoimmune shows a lot of fibrosis, and one has to see that it's classified separately. Will not go into the details, but among the autoimmune liver diseases, not autoimmune hepatitis, which are of 3 types, the clinician will tell you what kind of antibodies are present. It's difficult. You can't diagnose type 1, 2, and 3 based on biopsy. Primary biliary cirrhosis is the other autoimmune liver disease which is common. Primary sclerosing cholangitis is another one. And of course, autoimmune cholangitis. Please remember, AMA M2 is specific for primary biliary cirrhosis, right? And for primary sclerosing cholangitis, of course, changes are there and you get ANCA or no markers. And for autoimmune cholangitis, ANA and ASMA. Okay, right? So you can get an overlap. Please remember, this is typical of most liver diseases. Then when you get a biopsy, because the changes in the biopsy are similar. You'll get inflammation, you'll get cholestasis, maybe fatty change, you'll get necrosis. So it's a combination of all this, because the body in non-neoplastic diseases, especially inflammatory diseases, the reaction is similar. It may not tell you the etiology in every case. So therefore, it's always a clinico-pathological and laboratory correlation. This you must remember throughout your life. Please remember, whether it's renal, whether it's liver, especially in liver and GI. So it's a combination of all 3. And then, so you require a good clinical correlation. And in fact, you see in autoimmune, to diagnose, they use histology, they use this antibodies, absence of viral, and so on and so forth, and then they make a diagnosis. You must see interface hepatitis for autoimmune, hepatic rosettes, and emperipolysis. Emperipolysis is very important. Search for emperipolysis or lymphocytes or plasma cells within hepatocytes. This is important, and that you see. Okay, and you get severe hepatitis. You see this plasma cells. Remember, you can get plasma cells, but they're seen only in 2/3 of cases. It's likely in the case that you see, you will not get. Most of them are IgG positive. If it is IgM positive, think of PBC, right? And you can get eosinophils. There's a we talked about hepatic rosettes. There is another rosette in which you'll find the bile canaliculi in the middle. You may get bile. So this is a canalicular rosette. In autoimmune hepatitis and some of the other hepatitis, this hepatic rosette without a canaliculus is important. This for obstructive disease, even in some acute hepatitis, you can get cholestatic rosettes. And this is very important. Okay, you don't get that common in viral hepatitis. And this is the emperipolysis. Search for emperipolysis. You are likely to get. And if you get, it's very common in autoimmune hepatitis. Okay, and you get a lot of fibrosis. Cirrhosis is missed in almost half the cases. Sometimes you get extensive necrosis. It's fully necrotic. Look, all the portal tracts are close to each other. If you measure the liver span, it'll all be it'll be short. It'll be a short span. You know, the liver would have shrunken in size. You do an ultrasound at a small liver. Patient will be in liver failure because there's nothing. The liver is not functioning, right? And you get severe. Sometimes, rarely, giant cells you can get expression. There are various classifications we saw last time. We won't go into it. And what is this?
Ground glass opacity.
Where
Ground glass appearance.
the ground glass appearance. This is seen in hepatitis
Viral hepatitis.
B.
B. Very good. You can do immunohistochemistry for surface antigen as well as for core antigen. Okay, that's good. Okay, this is chronic hepatitis C. For hepatitis B, you have ground glass hepatocytes. If you can see, it's very helpful. Please remember the ground glass hepatocyte is okay. Ground glass hepatocyte will never be seen in acute hepatitis. If you see ground glass hepatocyte, it means it is a chronic hepatitis, right? Even if it presents with acute history, you find ground glass hepatocyte, it is chronic. There are two exceptions. One is when the patient is immunosuppressed post-transplant. Acute hepatitis, you can get. Chemotherapy, acute hepatitis, you can get ground glass hepatitis, right? And sometimes in a condition which is, of course, they say more common in immunosuppressed, there's a variety of hepatitis, acute hepatitis, in which you get fibrosis very early. It's called fibrosing cholestatic hepatitis. So this in this FCH, which is also seen in post-transplant or immunosuppressed, you can get ground glass hepatocytes. HIV patients, acute hepatitis, you can get ground glass, right? So this is very important. We'll come to those things later. Okay, right. Now, class, how do you grade? We grade and stage. Grading means, we'll come to all this in detail later. See, grading means how much of inflammation is there. Staging means how much it has progressed to cirrhosis. Just like grading of tumor means how much, here grading means how much it resembles the normal, just like in tumors. Means the inflammation is there, it doesn't resemble the normal, so how much of inflammation is. Staging is how far the tumor has progressed. Here it is how far the disease has progressed towards cirrhosis. And obviously, this is a part of healing and repair. So when there is inflammation and repair going side by side, it is chronic in hepatitis. So the inflammation part is graded and the repair part is staged. Okay. So you can get cholestasis, we saw, bile duct destruction. And when there is cholestasis, there are certain things that are excreted through the bile normally. And one of them is copper. So you can do an Orcine stain, you'll find this granular copper, or a rhodanine stain. This is for copper associated or binding protein. Protein that combines with copper and then goes out. This is for pure copper, that is the rhodanine stain. And you'll notice that this is the sinusoid, this is the sinusoid, this is the canalicular pole of the hepatocytes. And these granules are concentrated in the canalicular pole. This is very typical of most of the metals that is excreted, right? You see this copper binding protein is also this. So search for it like that. You'll get, and they are granular. So we won't go into the different criteria. Remember, for ANA homogeneous for autoimmune hepatitis, either alone or in combination with PBC. Pure PBC, ANA is dotted. And whenever there's biliary disease, PBC or autoimmune cholangitis, HLA-DR will be expressed in the epithelium. And we saw this, there's a granuloma. So this must be a PBC, but usually you can get it in overlap. In overlap, no, there'll be a lot of lobular inflammation. Rosette, this and that. Pure PBC, you don't get all those changes, right? So that's how you identify. For PSC, the gold standard is never biopsy. It is imaging. Either an ERCP, endoscopic retrograde cholangiopancreatography. They put an endoscope, they put it into the sphincter of body, they inject a dye. So retrograde, it goes into the pancreatic duct as well as biliary. Okay, so ERC cholangiopancreatography. So the dye goes up and then it you can see it brightens up the duct, the entire biliary tree, and if there is a block, you can make out. Same thing you can do by doing an MRI. It's called MRCP. Okay, in which you just do an MRI. It's a non-invasive. And when in typical of chronic obstruction is this onion skinning appearance. Around the bile duct you get onion skinning, and ultimately you'll get the bile ducts will disappear. So this is typical, and of course you will get copper, right? The other changes of large bile duct obstruction are you get all this bile incrustation, bile infarcts, and proliferation of bile ducts and cholestasis, canalicular as well as cellular, right? You can do a CK19 stain to find if the bile ducts are present. You can get this cholangitis or neutrophils infiltrating the bile ducts. Please remember, this is not necessarily bacterial, it is a chemical cholangitis. Bile is of two components, bile pigment, bile salts. Bile pigment, green in color, if you find it in the liver, it means cholestasis, or more specifically, bilirubinostasis. When you find inflammation, when you find necrosis, it's not because of the pigment. It is because of the bile salts which are toxic, which comes out of the hepatocytes or canaliculi. So just like acids, but the gastric acid, as long as in the lumen or on the surface, it's okay. If it goes in, causes problem. Similarly, bile salts. So these are all effects of cholate stasis or bile salts, where you get inflammation, where you get necrosis in the periportal area. This is just necrotic with encrustation of bile infarct. So all this is because of cholate stasis. Okay, remember that. And you get bile duct proliferation. So you can give a big description, write the grade and stage. This is the only one we gave. So let's continue from there. What we did. So this is a recap. Now, somebody tell me what this is. This is a portal tract, bile, right? This is you're finding lymphocytes, some plasma cells, and eosinophils. And you see this. This is the portal vein. Here also, this portal vein. That's the higher power of that. We'll go there. This is the portal tract. Okay. See, nothing much here. It's almost confined to the portal tract. This is the central vein. Again, you see this endothelial cells and this. What is this feature called? There is,
Yes,
you
sir.
should be able to, what is this?
The first picture, sir.
This what I showed.
So I'm not able to see a pointer.
Okay, ma'am. I'll just show you one second. This is an endothelial cell of the central vein
Yes, sir.
or terminal hepatic vein. You're finding lymphocytes here. Lymphocytes. Endothelium is lifted up.
Yes, sir.
What is this? Well, anyway, this is called endothelitis. This is typically seen in rejection
Rejection.
of an when you this is in the liver of the when it is transplanted and there is rejection, you get this reaction to see the liver is one of the immunologically privileged sites. Doesn't express HLA so easily. It's only in bile ducts as well as in the endothelial cells. So when there is rejection, the first effects are seen around the endothelial cells and then in the bile ducts. The hepatocytes themselves, it's quite privileged, immunologically privileged, like the cornea and so on and so forth. Unlike in the kidney, you require a nice HLA match and so on and so forth. So anyway, nowadays there are good immunosuppressants and all. So this is a typical feature. It looks like chronic hepatitis, but the difference is there is endotheliitis here, and of course biliary damage also. Okay, and you get a lot of eosinophils. This is not seen in so many in the garden variety. You can see it in drug-induced, sometimes in autoimmune. So each structure in the portal tract you must identify. Of course, if you have got a history, it is fine. See, this endotheliitis is also seen around the central vein. Right? So this is the diagnosis this endotheliitis. And of course, in chronic rejection, whether it's the heart, the lung, the intestine, or the liver, what happens is the blood vessels naturally they get damaged. Foam cells appear. They in fact close the lumen of the larger arteries, and the arteries almost disappear. So this is called foam cell arteriopathy or obliterative arteriopathy, which is commonly seen in chronic rejection. Endotheliitis you can get in acute and chronic, but predominantly in acute. And this is seen in chronic. This is just to show you, it may not come to you as a slide ever, but this, so it tells you that you must see each and every structure. This is a 14-year-old male with malaise 8 months, jaundice 8 months, raised bilirubin and transaminases. Okay, so this is a nice liver biopsy. Okay, nowadays they do a lot of transjugular also, which are very good. Through the jugular vein, they put in and then they take a biopsy. It goes through the hepatic vein, inferior jugular hepatic, and then inferior vena cava, and then the suprahepatic portion of inferior vena cava, hepatic vein. They take a biopsy. So this is done, and because if you are bleeding, you will bleed into the systemic circulation. If you are too obese, there is a site is difficult to get a percutaneous needle biopsy. You can get a transjugular. Okay, we'll come to that later. It doesn't make a difference. So you're seeing a liver biopsy. Yes, Ranjita, this is a liver biopsy, right?
Yes, sir.
Okay, this is the portal tract. There's inflammation here, right?
Yes, sir.
And this is looks like another portal tract. There's no way I can't see the central vein. This is portal tract. So when you're describing, this area will be zone 3. This area will be zone 2. Anything away will be zone 1, approximately it will be there. So the main seat of action is in the portal area and the periportal area. What are you seeing in the portal tract? Just tell me two things.
Portal vein, sir, and
Okay, and what is the abnormality here? There is
uh,
inflammation, no?
Yes, sir. Inflammation is
Lot
there.
of inflammatory cells. And anything else?
Bile duct is
Anything else in the inflammatory cells? Are they confined to the portal tracts or are
yes,
they
sir. It's
spilling into the lobule?
confined to the portal tracts, and a few are it's sinking into the lobules, sir.
Yes, yes.
It's
So that
going.
means what type of what is happening there? What would you call this spilling into the lobules called? What is this called? What type of necrosis? This is
Interface.
called, huh? Yeah,
Interface hepatitis.
it's called interface hepatitis or piecemeal necrosis. Very good, right? Very good. It's called interface hepatitis or piece. So there is portal inflammation. Once you see, is it moderate or mild or minimal? It is almost, you can't say it is moderate inflammation. Interface hepatitis, it's occupying almost 50% of the circumference. So it's at least moderate, okay? And then you see this is, what is this? See, there's
Sinusoid.
it looks like a sinusoid, but there is a collection of lymphocytes here, no? Bhavya, you see? And see, there is a hepatocyte here. You expect a hepatocyte here, but it is not there. So this is an example of spotty
Spotty.
necrosis.
necrosis.
This is what? Why? Because it is viral. And that's why you get lymphocytes. Okay? You're not finding the hepatocyte, it's gone. You see here, it's almost going. You can find this hepatocytes there. Okay? So they all die by apoptosis mainly. Right there. Okay? See here, this is another focus of spotty necrosis. Focus spotty necrosis. This mild inflammation. There is interface hepatitis here also. Right? What has happened to this? See, this is one kind of hepatocyte. Okay. Right. And these hepatocytes look little different, no? What are these? Compare this with this.
As if pseudo rosetting.
Pseudo rosetting. Rosetting will
Like,
be covered almost with the endothelial cell like that. No, but see this cytoplasm of this
Granular.
and this.
granular.
It's granular and almost hazy,
Very
no?
different.
Huh? So whenever you see this and different from that in um, in a chronic hepatitis, what do you suspect? When the cytoplasm becomes homogeneous. Anybody? In a chronic hepatitis?
Ground glass.
Ground glass.
Yeah, you suspect that it must be a ground glass. Typically, ground glass hepatocyte, the nucleus will be pushed to one side, or sometimes you cannot see because you see it's becomes little larger and pushed, and in the cut section you will not see in the sectioning. It's pushed to one side, and you find a little bit of the normal cytoplasm, and this will be like an inclusion. But sometimes you find like this. So that's why I focus this area for you. This is the typical ground glass appearance. See, a little bit of the normal cytoplasm. This is an inclusion like thing, and nucleus pushed to the periphery. Some you will not find the nucleus. So this is how the ground glass looks like. But you see here, it doesn't look like that. But even then, if it is chronic hepatitis and you are finding such cells, please suspect that it might be a ground glass hepatocyte. Okay. Then you do a fibrocyst. What does it show? Yes, tell me here. What does the reticulin, this is a reticulin stain. What does it show?
Nodule formations.
There is a nodule formation. This is a complete nodule. Here there's another one. Here there's another. So what do you think there is?
Cirrhosis.
Yeah, it might be cirrhosis. At least the severe inflammation. You see here, this is incomplete because we cannot see the complete thing in the meson strike. Okay, so this is the surface antigen staining. It is positive, isn't it? You're finding this is positive. So surface antigen is positive. This is the core antigen. Core antigen is mainly nuclear staining. Rarely you can get in the cytoplasm, but core is in the nucleus. Okay, right? So now we have come across this chronic hepatitis and we have done some stains. Let us see what are the stains that are done. See, most important HND in every liver biopsy is accompanied by diastase pass, a reticulin and Masson's trichrome. These are not special stains. These are the usual stains in liver biopsies. Special stains are arsine, pearls, rhodanine, stains for microorganism. Then you can do immunohistochemistry depending on what is required. In this widget, surface and core antigen. So this is a pass stain, not diastase pass. The problem with PAS stain is liver is abundant in glycogen. So it covers everything. You cannot see anything if there is an inclusion or say any organism or anything. It can't because the glycogen stains it. So that is why in the liver we do diastase pass. For example, the same case, this is diastase pass. Whatever is because of the glycogen is removed and the remaining pass positive granule. This is alpha 1 antitrypsin bond. Okay, this is seen in periportal hepatocytes. It's very good. You can find this PS positive, diastase pass positive material. Remember, if you get a ring form, then you're absolutely certain. Okay, this diastase pass for ceroid pigment in recovering hepatitis. Then this is the reticulin stain. Okay, Aska, can you tell if it is normal? This reticulin, is it normal?
Yes, sir.
It is normal. Okay. Yogita Himangini is not there. Ranjita, Teres, Bhavya, Aska, Rahul. Yes, Tanvi,
Yes, it's
tell me,
normal.
is it normal? Yeah, normal. It's okay. You tell me if it is normal or normal. Tanvi, what do you feel it is?
Tanvi is not there, sir.
Tanvi is not there.
It's there. Yes, some network connection.
Okay, Jyotika. Jalis, is it normal or abnormal?
There looks
Abnormal.
like parallel.
Huh? What is abnormal in this?
ज़्यादा fibrosis दिख रही है.
Where? This one? I'm asking about this area, Jyotika. Is it normal or abnormal? Anybody in the audience, is it normal or abnormal?
Sir, in the audience, they are saying normal.
Normal, okay. You see, when we tend to see only fibrosis in reticulin. A reticulin has to be seen carefully. Normally, I told you, the hepatocytes, they are arranged in a haphazard manner, like this, see? It goes like this, like this. The sinusoid has to go like this. It has to flow slowly. It can't flow directly, okay? But on the other hand, if you observe carefully, let me put these two arrows. You see what has happened to the sinusoid here? It is becoming parallel, no? Do you agree?
Yes, sir.
The liver cords are becoming parallel. So this is an early example of loss of architecture. People right now, loss of hepatic architecture. What is the abnormality in that hepatic architecture you're seeing is this parallel lines of hepatic cords. So this has to be seen. Today, when you go from here, you must see all reticulins carefully. That is the early change where the hepatocytes align themselves in a parallel manner. When you see that, that means it's abnormal. abnormality is starting. Even before the fibrosis starts, this remodeling is occurring, and because of there must be some fibrosis, some changes, and this is, see, normally it should be like this. Okay, so that is number one. Number two, you're finding is that the reticulin delineates all the sinusoids. If it is not delineating, then it is abnormal. See, then of course this is cirrhosis. A reticulin, if you do a biopsy, you can find just a nodule that is coming, and all around the nodule you're finding this. So it helps in identifying changes in architecture, identifying nodules, and see in the normal liver it's like this. Okay, then you see it is lost. Reticulin gets lost in hepatocellular carcinoma. This is a poor man's stain of telling you that this is an HCC. You pull out HCCs and you do reticulin, you will not find. In an adenomatous or dysplastic nodule, it becomes less. The only exception, of course, is fibrolamellar, where there's a lot of fibrosis. That type of HCC you will get. And fibrosis is like this. It's not like collapse. Collapse I showed you in the earlier one. Fibrosis, you'll get these linear strands. So reticulin tells you so much information. Not necessarily just fibrosis all round. You see all this, right? So this is very important. Then when you find a nodule, if you find this parallel arrays of reticulin around a nodule, separated out, see here one, it gives you a feeling, no? It's almost like onion skinning around a nodule. When you see that, think of obstructive etiology or cholestatic etiology. So if there is biliary cirrhosis, you're likely to get these parallel things because there's a lot of perinodular edema and the reticulin fibers separate out and they arrange themselves as if there's onion skin. So you see the reticulin helps, it gives so much information when you do it properly. Then for example, in this case, this is a case of portal hypertension. Okay, these are what are these? Avya, what are these structures?
Central veins.
Central vein autonomy. Okay, Ranjita, what is this?
That's a portal tribes.
Right, good. Is it normal, abnormal? Jyotika, Rahul, Jalis, is it normal, abnormal?
Which one, sir?
This patient has portal hypertension.
So clear, sir. Actually.
It looks normal. Okay. But then you do a reticulin stain, you see this is a nodule. But not because of fibrosis, because the hepatocytes have arranged themselves in the form of a nodule next to a central vein. This is what you get in nodular regenerative hyperplasia. You get nodular regenerative hyperplasia in many conditions, very common in hematological conditions, very common in non-cirrhotic, you can get in non-cirrhotic portal fibrosis and all. So in that, you will not find anything much, nothing much. Of course, if you're experienced, you can find out, but generally you will not find anything much in the HND. You have to do a reticulin stain. So you see, reticulin tells you so many things if you identify properly. So go back and see the slides with reticulin. This, of course, Mason's trichrome. Normally, you'll find it in the portal tract and a thin rim around the central vein. So whenever there's fibrosis, then of course it helps, right?
Sir, an attendee is asking for reticulin arrangement in fibrolamellar carcinoma.
There's no specific arrangement, but you will find, see, you will not find the sinusoidal arrangement, but you will find fibrosis. There's no sinusoids in between. But these are all hepatocytes here, there. Malignant hepatocytes are here, there. But you'll find this fibrosis. In HCC, you will not find. In an adenomatous or a dysplastic nodule, it will be reduced. You see, here it is there, but here it is not. So reticulin tells you a lot of stories. Okay, now mesons, see, mesons we just say cirrhosis. Now look at this cirrhotic nodule. Who is that now? Who hasn't answered? Has everyone participated? Jelly's Tanvi is not there. Tanvi has not joined. No? Jyotika. Jyotika? Jyotika is not there?
Yes,
Sonal?
sir.
Jyotika, what is, you look at this one, okay? This cirrhosis, you agree?
Yes, sir.
Okay, look at this cirrhosis and this cirrhosis. What is the difference between the two?
This slide में fatty changes भी दिख रहे हैं.
No, okay, about the cirrhosis. Forget about fatty chain, Jyotika. छोड़ दीजिए. Blue and red, just these two colors.
More of fibrosis in the first picture. It's like the second one, there is sparing of the the hepatocytes compared to the first one, which is more fibrosis.
Okay, Jalis. There is
Sir, it's looking more map-like in the second one.
the first
It's
one.
not.
First
First one, the fibrosis is encircling the nodule completely, sir. The nodule formation is not very evident in the second.
Yes, Bhavya, Ranjita is very important. That's why I'm asking everyone.
First one looks more of a fibrosis as compared to the second one, sir.
Bhavya, what do you feel?
So the nodule formation is complete in the first one, sir. But the second one is not showing that much of fibrosis, not complete nodular formation.
Rahul, what do you feel?
Sir, in second one, necrosis is also there, sir.
You see, just look at the red color with the hepatocytes and the blue color, and look at the pattern. Here it is rounded pattern. Here it is what Teresa said, map-like. It's not completely round, no? It's like jigsaw puzzle. You see, rounded jigsaw puzzle. Are you appreciating this? You see here, it is like this, irregular shaped islands with fibrosis. You look at this. There's fibrosis here, but irregular shaped island. Here it is rounded. You're finding this? Rounded, rounded. It's not irregular, it's more or less rounded. Sorry. This one you should keep in your mind. Yes, I agree. This is little rounded, but slightly irregular here. This is all irregular. These are two very important patterns that you must recognize. Whether the nodules are round or whether the nodules are like jigsaw puzzle or map-like. These rounded nodules are seen in post-hepatic cirrhosis. Remember that. This is seen in other conditions. You can get in metabolic, like Wilson's disease. You can get in secondary to biliary obstruction. So you see this ultimately, when it is long standing, most of them they become rounded, right? So, but in early cases, like for example, extrahepatic biliary atresia early cases, you will find nodules which are like this. In later cases, gradually they become smaller, smaller, and they become rounded. But this is typical of post-hepatic, hepatitis B, hepatitis C, okay? And in NASH and all, of course, you find little more fibrosis going in between. So this one, you just keep this picture in your mind whenever you see this, okay? Right. What is this stain? Rahul, tell me, since you are there. What stain is this for fibrosis?
Orcine, sir.
No, this is not orcine. This is Sirius red. Okay, orcine will be brown in color. This is Sirius. Orcine is like this, more dark brown in color. This is Sirius red. Okay, orcine is this color, and this is reddish in color. Sirius red. That's a very good stain for fibrosis. Very simple. For VUG, you can do that. And orcine, of course, you see copper associated protein, copper binding, they are granules. Remember, they are granular. HBsAg, it is diffuse orcine stain. Surface antigen, core antigen. Core antigen is nuclear stain. Right? Now, surface antigen, you see, you must remember for hepatitis B, 3 antigens: surface antigen, core antigen, E antigen. In the serum, you can detect only 2 antigens: surface antigen and E antigen. By immunohistochemistry in the tissue, you can detect only 2 antigens: surface antigen and core antigen. So surface antigen you can detect by immunohistochemistry, surface antigen you can detect by serology. Core antigen you can detect only in the tissues. E antigen you can detect only in the serum. So remember these 3 antigens. Surface antigen tells you about the surface antigen. Now the core antigen correlates with the E antigen status. If core antigen is positive, then E antigen will be positive in the serum, generally. This is important because core antigen means the virus is replicating. That means DNA of the virus is increasing. And E antigen also means almost a similar thing. You can do a HBV DNA, it may correlate with the core antigen. Now the core antigen, if it is present, the virus is replicating and the E antigen is present in the serum, it means the patient is infectious, more likely to spread infection. Otherwise, the husband, it may go to the wife, or the same household, children, wife to husband, so on and so forth. Right? So they are more likely to spread. If you are there as a healthcare worker, you're likely to spread more and so on. So now if you do surface antigen alone, you can find 2 patterns: diffuse pattern, granular pattern, and a membranous pattern. If you find a membranous pattern, you are likely to get core antigen positive. So a membranous pattern of HBsAg correlates with E antigen status and infectivity of the patient and with core antigen, right? So you remember this. So you have diffuse, granular. Sir, if the cytoplasm is positive, it's like any surface. We'll not go into the details. A lot of things you can talk about this. But remember, if it is membranous, it's more likely to be E antigen and core antigen positive. Core antigen you can get in the nucleus, sometimes in the cytoplasm when it is a little more. So you have to do in the tissue, surface and core antigen. I hope this point is clear now.
So,
Okay? Right. So you have learnt about the special stains and 2 things. So when you write a report, you can be very short. It says chronic hepatitis. Core antigen is positive, so it's replicative HBV etiology. Whatever may be the clinical thing. You have found it in the tissue, you can write this. It's replicative HBV etiology. Mild to moderate activity, significant fibrosis, international liver group, grading A3, B0, C2, D3. It means how much of lobular inflammation, lobular necrosis is there, whether it's confluent necrosis, how much is there, interface hepatitis and portal inflammation interface hepatitis. You give and then add the total value, maximum how much it is. So in this scheme, see 1, 2, 3, 4 is minimal activity. 5, 6, 7, 8 is mild activity. 9, 10, 11, 12 is moderate activity. 13 to 18 is severe activity or severe inflammation. Okay. 1, 2, it's like your fingers, you can just count. 1, 2, 3, 4. First 4 is minimal. 5, 6, 7, 8 is mild. 9, 10, 11, 12 is moderate. 13, 14, 15, 16, 17, 18. The remaining 6 is severe. Staging, anything more than 2 becomes significant. And 6, of course, is this. Oh, there was something somebody wanted to ask. Was there a question, Sonal?
No, sir. Sir, Babita Sodhi is asking for the book which you'll follow for liver biopsy. That is all.
Okay. We follow many books, Babita. You can, I will tell in the end. Okay. So this is important. Now, once you see ground glass hepatocyte, the only thing that looks like ground glass hepatocyte, no. There are many other things that can look like. This is fibrinogen storage disease. Looks like ground glass hepatocyte. This is Lafora body. Lafora body is seen myoclonic epilepsy or Lafora body epilepsy. You know, you can get like these inclusions in other organs also, in the liver also. This is Lafora body. It looks like that. This is type 4 glycogen storage disease. You can get sometimes like this ground glass, sometimes you can get big granules. Type 4 glycogen storage disease is amylopectinosis. This looks almost alike, just like this you can get. Now, this is globular amyloid. Although it's slightly bluish, this is globular amyloid. Amyloid, you can get diffuse. You have seen, I think, all of you would have seen slides of amyloidosis. This is globular amyloid. Please remember, when you see like this is not fitting into hepatitis, do at least an amyloid stain. And this globular amyloid is related to a cytokine related to leukocytes. You can read that up. Will not go into the details. Okay. Then you see here there are other conditions in which you can get these inclusions in certain drug-induced conditions also, right? So you get like these inclusions in other conditions in hepatitis. So don't worry, there are 101 conditions, but most common. These are once in a way rare instances where you can get these changes. Okay, so don't worry about that. And by the way, these are pale bodies that are, I forgot to tell you, this is seen in fibrolamellar hepatocellular carcinoma. Okay, they may contain glycogen or copper in them, and these are hyaline bodies. Don't mistake them for any other thing. Hyaline bodies seen in hepatocellular carcinoma. They may be rich in various proteins, including alpha fetoprotein. Okay, so these are the other conditions which can look like that. Chronic hepatitis C is different from hepatitis B. You don't get surface antigen. Usually the inflammation is not very severe. It is very patchy, and you can get fatty change, especially in genotype 3. There are many genotypes. Fatty change can be seen in hepatitis B also. We see fatty change in 25% of our hepatitis B, but in about 40 to 60% of our hepatitis C. So it's more common in C than in B. Some genotypes of hepatitis C may not get that fatty chain, mainly a cytopathic effect. So you write chronic hepatitis, HCV etiology by clinical history. You can't make a diagnosis. Mild to moderate activity, minimal fiber, you tell whatever, the same thing. Okay. Right. Now you see grading, you have to grade the changes. How much of inflammation? Spotty, confluent, this is more of confluent necrosis. So this is how you grade. Very severe, panlobular necrosis, bridging necrosis. So grading includes all those types of inflammation and necrosis in the lobule. Inflammation, necrosis in the lobule. In the portal tract, inflammation and piecemeal necrosis. Two things. In the portal tract, inflammation, piecemeal necrosis. This gives you an example of how much of piecemeal necrosis is there. Mild, moderate, severe. Okay, right? So you can see this. It also, you have to tell how much of inflammation is there in the portal tract. You see here, the piecemeal necrosis is not as much as this, but the portal inflammation is more. Right here, there's quite a lot of piecemeal necrosis going all around. So all this. So how do you grade? It's basically like this. Suppose this is the portal tract, and this garbage is the inflammation, and sorry, this should be the lobule. Okay, portal tract and lobule. So little bit of garbage going into this is minimal. Okay, the little more moderate, and this is severe, where everything is almost going out. Eh? So this is how you say mild, moderate, and severe. What is important is when you identify in a low power, you look at the portal tract. Is it irregular because of the inflammation, the inflammatory cells or not? If it is irregular, you're likely to see interface hepatitis, right? You see, this is quite good, you know, quite confined. Here you see, it doesn't look, the margins looks irregular. So you see this you don't expect in interface hepatitis. This. So in the low part, this is how you identify whether you're going to see interface hepatitis or not, right? So no activity, minimal activity, moderate and severe, okay? So and then fibrosis. There are different ways. No fibrosis, portal tract is enlarged with fibrous tissue. Portal fibrosis with septa, few lines, few septa are going out, and numerous septa, but it's still not cirrhosis. And cirrhosis. This is 4-tier system, 0 to 1, 2, 3, 4. They could have a 6-tier system also. So 0, 1, 2, and this is the 1 and 2, 3, and 4. They have combined that, okay? No fibrosis, fibrous expansion, fibrous septae, and cirrhosis. So this is the 4-grade system. And you know, staging is very, very important because the diagnosis depends on how much of fibrosis is there. No fibrosis, good. And if you see cirrhosis, it just falls down. Within few years of follow-up, so many people die, you know. So that's the thing. So now, how did all this grading? The first thing was started was in 81 by Nodel and Ishak. So they did all this periportal bridging necrosis, interlobular necrosis, portal fibrosis. They started giving scores, giving numbers. Earlier it was not numbers, you know. But there is some, this was the best thing that could have happened because numbers make it more scientific and more objective. But there were some problems in that. For example, it combined inflammation as well as fibrosis, the total score. So that was one problem. It shouldn't have been combined. Secondly, there were some jumping numbers, like for 0, no periportal necrosis or piecemeal necrosis. 1 was mild piecemeal necrosis, and 3 became moderate. There is no 2. Similarly, marked piecemeal necrosis plus bridging necrosis was 6, but when it is panlobular or multiacinar or necrosis, it became 10. 7, 8, 9 were missing. Similarly, these were the points that were considered little critical. People were critical and they said it needed improvement. Nevertheless, this is one of the best things that would have happened in hepatology and further research. So then Shaya brought out, I worked under him, and he brought out the 0, 1, 2, 3, 4 for periportal activity, lobular activity, and 4-tier for cirrhosis. He simplified it, and this was the first beginning. Then Batts and Ludwig started another thing. Then the Metavir algorithm came in 1994. The French people did that. This was an algorithm for hepatitis C because they were studying drugs and other hepatitis C, and they brought out something which was more specific for hepatitis C. And then in 1994, this is the modified hepatic activity index grading, which was done by a group of international pathologists, which included Ishak of the Nodal and Ishak and Scheuer and all of them. And they made it into a total of 18. A, B, C, D refers to the lobule. Periportal or periseptal interface hepatitis, confluent necrosis, spotty necrosis, portal inflammation. 4 things graded 1 to 4, right? And except this one had up to 6, and the staging also there was up to 6. Okay. So they all are comparable, you know. So it's all similar. You have to use any. Now, it was seen in hepatitis C and B. This grading and staging is important. More the fibrosis, more the prognosis became poor. And this became important for drug trials and for assessing prognosis. But one thing was known, you know, if you take biopsies from the left and right lobe, there is a difference in the grade. You take 2 biopsies or from left and right lobe or paired 2 biopsies, there is a difference in the grade and stage. So this was, people started becoming critical of this, and now we know that they want to do the fibrosis of the entire liver. They use non-invasive techniques, ultrasound and so on, fibroscan and so on and so forth. But anyway, this is still the gold standard. To get the best result, you must have long biopsies. That's known. But what is important is there are certain rules. First, the biopsy must be adequate. Secondly, you know, these are used for comparing biopsies of the same individual. For example, if somebody had an inflammation grade of 8 before and now it has become 7, there is no change. If it becomes 6, he has improved. From 8, if it has become 9, that is 1 increase, no change. From 8, if it has become 10, that means he has deteriorated. So this is used in the same individual. Secondly, staging from 1, if it has become 2, he has deteriorated. From 2, it has become 3, he has deteriorated. From 2, it has become 1, he has improved. So one change in the stage or two-fold change in the grading scores are considered to be prominent, are considered to be significant. Now, staging is very important. People said, does the staging correlate with the amount of collagen? No, it does not. In fact, this is a nice study by Standish and Dillon, with whom I worked also. Then, you know, for stage 1, 2, it becomes linear. Then suddenly it becomes linear, it becomes, it rises very rapidly. Again, it tends to more than now. That is because we don't measure the thickness of the septa. We don't see how thick the septa is, thin or thick or whatever. The thin septa around the cirrhotic nodule, we still call it cirrhosis. So the amount of collagen varies with this stage. So you must be very careful, otherwise it will be in a straight line. So this is grade 3 histological stage 6. If you tell this to the clinician, it will convey something, but he'll not understand it well. If you write this line, cirrhosis with mild inflammatory activity, it will appeal to him more. So therefore, in your report, both this sentence as well as the numerical grade and state should be conveyed to the clinician. It's much better way of communicating with him. Now, as far as cirrhosis is concerned, there are certain things new. You must remember that cirrhosis, some forms of fibrosis are reversible nowadays. It is not that one fibrosis gone forever. So that is why what we see is we have found that small nodules with thick bands have a worse prognosis than large nodules with thin bands. Told you the amount of collagen will be less in this. So small nodules, thick bands, worse prognosis, large nodules, thin bands, good prognosis. So like that, we have classified cirrhosis. This has been classified. And it's important because you see the any hepatic wedge, hepatic venous pressure gradient is they measure it, and if it is more than 10, it is significant. Okay. So if you'll find that if it is thin septa, the gradient is less. When the septa becomes thicker, the gradient becomes more. Similarly, if the nodules are small, see the gradient becomes more, and if the nodules are large, it becomes less. So that is why it also correlates clinically, with the portal hypertension and other changes. So therefore, you classify cirrhosis into predominantly progressive, small nodules thick, or thin nodules or incomplete nodules with thin bands and the nodules are larger, predominantly regressive. Okay, so two kinds of cirrhosis. That also, if you can convey to a clinician, it is well and good. There is a Beijing classification for this. So you see, predominantly regressive, you see, thin band, large nodules. Predominantly progressive, thick bands, small nodules. And this is indeterminate, in between the two. If you can tell this this conveys an additional information. So this is something new. You just remember this. Now we come to the immunohistochemistry, what we do, just for non-neoplastic. See, there are various cytokeratins. Remember, 7, 8, 18, 19. Two continuous ones, 7, 8, 18, 19. Okay. This could be by 11. Okay. Now remember these two cytokeratins. We'll take 7, 8, 18, 19. All the four will stain hepatocytes. All four. 7, 8, 18, 19. But 7 and 19 will stain only the bile ducts. So you do this. You do this 8 and 18 will stain the hepatocytes as well as the bile ducts. 8, this staining is generally a little patchy and less compared to 18. Whereas 17 and 19 will stain only the bile ducts. So if you want to see whether bile ducts are present or absent, choose 17 or 19. Usually 19 is chosen, it's a little darker staining. Okay. If you want to check whether the hepatocytes is there or not, you can do 18. Okay, 18 and 19 a good stain, or 8, 18 you do, and 7, 19. So this is what you can do for bile ducts and hepatocytes. You can do it for tumors also. The other ones which tell you whether they are hepatocytes or not are HepAR1, okay, which is a carbonyl phosphate synthetase. So it is one of the enzymes which is rate limiting in urea cycle, and it's located in mitochondria. It's supposed to be present in, you can do in immunohistochemistry in paraffin section. That's why it's called PAR1, HepAR1. But studies have shown it works sometimes in frozens also. Then arginase 1. It is again in the urea cycle. It hydrolyzes arginine to ornithine in the periportal hepatocytes mainly. So arginase 1 is another immunohistochemistry you can do. Glycopan 3. Now, glycopan 3 is not present in adult liver. It is expressed only in fetal livers and placenta. And in tumors you can get because it becomes almost fetal. And glutamine synthetase, it's again related to ammonia metabolism. Converts glutamate to ammonia and ammonia to glutamine in the liver, and it's related to beta catenin. So in the normal, it is expressed only around the veins, mainly around the central vein and sometimes portal tract. So these are used mainly for tumors, not for the non-neoplastic disease, but good to know that they are there. Polyclonal CEA as well as CD10, it'll outline the biliary canaliculi. So it's important in that. So, and that's why it is present both in normal liver and in HCC. CD34, normally there are no capillaries in the liver, no? So the positive staining is not there in the normal sinusoid. But in hepatocellular carcinoma, there's changes in the vasculature, you will get CD34 staining. Bile salt excretory protein, it outlines the canaliculi. This we use in some of the neonatal hepatitic disease. Alpha fetoprotein, it does not stain normal liver, just like the glycopan 3. No, it does not stain. But it is seen in some cases of cirrhosis and HCC, and whenever the alpha fetoprotein is raised. So these are the certain immunohistochemistry. Now, male diabetic 20 years, who will take this case? Come on, Ranjita, quick. Now these cases are fast.
The
Diabetic
patient
20 years, 30, yeah, okay.
patient is 35 years old
Yeah,
and having
35,
diabetes for 20
diabetic
years.
and elevated
Diabetic,
transaminase, 4 months,
yes.
all markers negative.
Uh,
What are you finding? Low power.
In this two
What's
linear core,
yes?
I'm seeing more of a microvascular steatosis
Okay.
and periportal inflammatory infiltrates.
Which on this portal tract is it? Is it in which zone is it present?
Zone 3, zone,
Okay, zone 3
zone
and zone
3,
2.
yes,
Yeah?
sir.
This is
Yes,
this, you see this portal tract, away from the portal tract, there's this structure, might be central vein.
yes,
So
sir.
it's more in the, yeah, zone 3 and 2. But here it is going maybe up to zone 1, away from the portal tract, okay? But here I agree, it's mainly near the zone 3 and 2. Good. What percentage do you think? Rough estimate, all the fat, all the hepatocytes, 1/3, 2/3.
2/3.
Okay. Okay, 1/3 to 2/3. Good. What else are you finding here? What are these areas?
Training.
This area, this area, this area.
Basal necrosis.
No, no, Ranjita, you're using a wrong term. Piecemeal necrosis is interface in between the portal tract and this. This is not near the portal tract, no? It's in the lobule. Let's ask Therese.
Yes, sir. There is lobular inflammation, sir.
What is it? But lobular inflammation is fine. But what term will you use? What kind of lobular inflammation?
Spotty
Yeah.
necrosis.
Spotty.
Huh? Yeah,
Spotty.
who's that? Ah, Ranjita, spotty. Okay. This is spotty. I agree. This is a bit of a confluent,
Confluent.
maybe 2, 3. Small foci of confluent. This is spotty. This may be spotty. It's a matter of opinion after some time, you know. Okay. Anything else you are finding? Nothing. Finding fat. Okay. Very good. Same thing. What this must be the central zonal area. Okay.
Mhm.
You're finding fatty change. You're finding here. with a little, maybe 2, 3, you want to call it small foci confluent. It's well and good. Spotty necrosis. Here spotty. I hope all of you are able to identify this. Okay, good. Right? This is a fatty change. Right? Yeah, there must be some fibrosis that's going on here. And look at this. This looks like almost like a Mallory's island here.
Right.
This is okay. Right? Okay, there's fibrosis. See, Mason's trichrome, this is the portal tract. This is away from the portal tract. There's some fibrosis even in the centrizonal area. Okay, and you're finding fat. And in Mason's, it shows that at least in this, the fat is away from the portal area. Okay, right? There's fibrosis. And fibrosis, you see, it's encircling some hepatocytes here. Okay. So, any other investigations? What is your diagnosis?
I'm considering, since the patient is diabetic for 20 years, I'm considering it can be associated with metabolic associated liver disease.
Okay, metabolic associated liver disease. Okay. Aska, what do you think it is? All of you agree? What she told?
Yes, I think it is a
Yes.
fatty liver disease. It is a fatty liver disease. We have to see whether it is an alcoholic or
Is there a
non-alcoholic.
steatohepatitis or not?
The steatosis is seen.
Is there? Is there a hepatitis or not?
No, wasn't there. Couldn't see much of ballooning or any change except for
Found
the
some
macros.
inflammation, no?
Yes,
Portal
inflammation was
inflammation. Okay. All right. Now you see, so there is some amount of hepatitis. Okay, and let us see this. See, this cell is balloon, no? Which you didn't tell. See, this is larger than the normal hepatocyte. This is because of fat. There is a difference between those with fat and without fat. See, for example, I'll show you the other one. We'll see the other case, I'll show you. You have to identify, this is all enlarged because of fat. There are some cells which are, you see, where the Mallory's hyaline was there. See, the nucleus is rounded, not pushed to the periphery. This would be a balloon cell. Okay, see, this is a balloon cell here. Okay, this is a balloon cell here. So, whenever the vacuole is sharply punched out, is likely to be fat. When it is enlarged with the nucleus in the center, it's likely to be a balloon cell. Okay, so that's how you identify. So anyway, this is NASH. So what is fatty liver, Bhavya, and how much of fat is abnormal in the liver? How much of fat is abnormal in the liver? And if somebody says fatty liver, what does it mean? What fat is there?
More than 5%.
Okay, and what is fatty liver? So it is more than 5% by weight. Okay, and so it is actually accumulation of triglycerides in hepatocytes. So accumulation of fat in hepatocytes is called steatosis or fatty liver. So that should be the definition. And what kind of fat? It's predominantly triglycerides, not lipoproteins, not VLDL, not free HDL or something like that. It's mainly the triglycerides. Okay, in the hepatocytes, it's steatosis, more than Anybody can tell why it is 5%. Why not 10%? Why not 2%? Anybody in the audience? Rahul, can you tell? Jyotika, why it is 5%? Just think. Rahul?
Fat storing cells are normally present, sir.
So why 5? Well, anyway, there have been a lot of studies. Some are biochemical studies, some are histology studies, and some are imaging studies. Most of them have shown that it varies between 2 and 5%, although some have shown that it can be as high as 9% or so. And depending on the ultrasound and other things, ultrasound, when you get ecogenicity, there's certain changes I'll show you. So all of them, then the consensus was 5% should be the cutoff. So, and there have been histology studies in many people actually, right? In fact, Brunt studied almost 1,000 cases in adults, and autopsy studies and all others. So that's how 5%. See, normal appearance of the liver, if there is diffuse fatty liver, no, you see, this is the normal appearance. It should be dark. So in fatty liver, it becomes bright by ultrasound. So that is, the ecogenicity will exceed that of the normal liver or that of the right kidney or one of the kidneys, adjacent kidney, they will see, or the spleen, they'll compare and see if the ecogenicity is increased or more bright, then it's fatty liver. And if you are a radiologist, you'll know how to grade how much there is. In CT scan, it's the opposite. Normally, this so you see this is the normal bright thing, this is fatty liver. See? So you compare with that, it becomes little dark. So you compare with the attenuation, what you get in the spleen, it is more darker. So then you say that there is fatty liver. There are values, these are the Hounsfield values. We'll not go into the details today since this is not on fatty liver. So that's how people can diagnose. And of course, there's loss of signal intensity in MRI. We'll do that. But the sensitivity and specificity are not that good in ultrasonography compared to CT or MRI, but this is very easy. It's like a stethoscope for gastroenterologists. They do it and it's quite okay. Okay, so, but NAFLD means fat accumulation of liver in the absence of excess alcohol. 20 gram for men and 10 gram for women. And you have to rule out other causes of steatosis. So it is by a diagnosis of exclusion. So this is normal liver. So this will become fatty liver if it is more than 5%. Remains inside, it's quite okay. That's steatosis. But the moment there is inflammation, it becomes NASH. So all the spotty necrosis, ballooning, and so on and so forth, it becomes NASH. So if you see inflammation become that is what we do. That's the problem in this. And once there is inflammation, long time, there'll be healing and repair. So there'll be fibrosis and cirrhosis. So this is what you get in NASH, right? So fatty liver disease, steatohepatitis, fibrosis. We'll come to the terminologies now. So this is how it is, and it progresses. So mainly in zone 3, right? Fibrosis also in zone 3. Mallory-Hyalin, you'll get very little compared to alcoholic. And you can get megamitochondria. Okay? So you get all these changes. Now many confuse between microvesicular and macrovesicular. Please remember, microvesicular, the vesicles are so small that you may have to do a fat stain to identify. It looks like almost like a slightly vacuolated or ballooned or pale hepatocyte. That is microvesicular, typically seen in, say, Rice syndrome that you get in children, or fatty liver of pregnancy, or tetracycline poison. The rest are all macrovesicular. You see, this is macrovesicular steatosis, whatever you see. And this is microvesicular, very high power. Very, very small vacuoles. They're almost homogeneous, right? And in fact, these droplets are large droplets, in which the nucleus is confined to, goes to the periphery, and these are small droplets, which you can identify the droplets. It's a small droplet, macrovesicular steatosis. This is microvesicular. Sometimes they coalesce to form fatty cysts in the liver, small fatty cysts. Sometimes you get a granuloma, what is called an oleogranuloma, fat ruptures, and then you get a granulomatous reaction. Okay, so you see this is a small vesicle, and then Mallory's island is ropey, like this. It's almost like a rope, and invariably the cell will be ballooned out. In those cells, you search for Mallory's island. These are all inflammatory cells, which are lymphocytes. Then what is this nucleus? There is
Glycogenated, sir.
glycogenated nucleus. Very good. This nucleus,
Also,
this nucleus, nucleus. What is this, this, and this? Here,
Both
there
look
is these two, these
also,
two.
there's a
These are,
membrane around the
okay, they are membranes. So they are glycogenated or not?
glycogenated, sir.
With a membrane. And this is glycogenated without a membrane. Okay. This is microvesicular, this is macrovesicular, large droplet, small droplet. Okay. Yes, you are right. There are two types of glycogenated nuclei which are recognized now. One is with a membrane, which is type 1, and another without membrane, which is type 2. So this is type 1, this is type 2. Okay. And both nuclear inclusions you can get in a fatty liver and NASH. But in NASH, no, without the membrane is more common. It's almost 3 times higher. So if you get a case of NASH, you'll likely to get this type 2 more than type 1. Okay. But if you compare normal individuals to NASH, you will get both of them. But if you take all the NASH cases, this will be more than this. So this is something for you all to, something new that you need. What are these structures? Yes,
Mallory.
Jalis, what is this? Jalis?
So, like,
This is some globule like,
glo-
yeah? Yeah, Sonia Agarwal has written, it is mega mitochondria. They are large mitochondria. You know, all this fatty change and all causes beta oxidation, this and that. So a lot of changes are there. The mitochondria enlarges, mega mitochondria. And the fibrosis in NASH alcohol is typically chicken wire. You know, this is the chicken wire. So you get like this. Unlike in other types of cirrhosis, no, you don't get so much intercellular fibrosis like in NASH or alcohol in other conditions. See, this is what the type of fibrosis you get in other conditions, but in NASH and this, you will get like this. So this cirrhosis, and you ultimately will get cirrhosis. Now, in pediatric cases, there are two types of is NASH, type 1 and type 2. Type 1 is less common, type 2 is more common. Okay? Type 1 resembles the adult pattern and is common in girls. That is, the fibrosis, everything is more centrally located. Type 2, you get more fatty change, but fibrosis is mainly portal base. Type 2 is more common in boys, right? So type 1 is like adults, more in girls. Type 2 is mainly portal base, more common in boys. But many cases there will be overlap between the two. Remember this in pediatrics. So the grading of NASH is done by steatosis, ballooning, inflammation. State Bank of India, SBI, you remember, you'll never forget in your life. Steatosis, less than 33, 33 to 66, 66. Ballooning, minimal in zone 3, present in zone 3, marked in zone 3. Ballooning. Lobular inflammation, how much it is there, okay? How many foci? 0, less than 2, 2 to 4, and more than 4. And portal inflammation, same thing, mild, moderate, severe. 1, 2. Okay, so there are others for the NAFLD grading. So this is how it is done. So steatosis, see this is grade 1 and this is grade 3. Lobular inflammation, so less than 2 foci in 20x field, 2 to 4 foci in 20x field. So like that. And you do it. Please remember, if steatosis is 0, it is not non-alcoholic fatty liver disease. If the ballooning is 0, then of course it is not NASH. It has to be NAFL. If the lobular inflammation is 0, it is not NASH. It has to be NAFL. So if it has to be NASH, there has to be at least one of steatosis, at least one of ballooning, and one of lobular inflammation. At least minimum of all these three combined, then only you call it NASH. And NASH is what we are worried about. So anyway, there are different staging and this one will not go into this. Okay, so these are these things. Please remember, just by adding up scores, don't make a diagnosis. Please, you make a diagnosis, then you make the scoring. For example, this is a study which showed that if NAS is more than 5, in 3% it was not NASH, in 11% it was borderline NASH, and it was definite NASH in 86%. Therefore, in 15% it was not. If it is less than 4, the score, it was definite NASH in 30%. So you see, you can make mistakes. First make a diagnosis, then you do the scoring for anything. That's very important. Okay, now this case history next. Jellies, you take it, 58-year-old female, ascites, pedal edema, hypothyroid, non-alcoholic, ascites, nodular liver, viral markers negative. What are you finding?
So in this case, I can see there is steatosis,
Yes, very good.
which is about 1/3 to 2/3
Uh,
of the core biopsy
mm,
involvement. I can see mostly macro vesicular steatosis. In
fine.
between, I can see a portal tract.
Any
Uh,
inflammation?
yes, sir. There is inflammation. Looks like a lobular inflammation in this power.
Okay, there's steatosis, there's inflammation. And there was ballooning in this. Yeah, well, this is ballooning. Correct, you're right. High power, you know this one, it's called Mallory. Nowadays, they call it Mallory Denk body because Mallory first identified it and Denk did the animal experiments using greaseofulvin and created Mallory bodies. and there is fibrosis. Good. So micronodular cirrhosis secondary to non-alcoholic steatosis. Now tell me, what is the difference between micro and macronodular? Jyotika, what is the size of the nodule? Micronodular and macronodular. Anybody?
Based on size,
Huh?
3 mm.
3 millimeter.
3 mm. Why 3 mm? Size of a lobule is about around 1 mm. So why not less than 1 mm? Well, actually, an international group sat long time back and they found that, yes, they said that if you make 1 mm, everything becomes macronodular. Very difficult to identify grossly and microscopy. So they arbitrarily cut it at 3 mm. And they said whatever is below 3 mm is micronodular, whatever is above 3 mm is macronodular. Now size is not only size is important, there is another feature that is very, very important, especially grossly. This was a WHO committee held by P.P. Anthony Ishak, and my teacher, Dr. Nayak, was also there, and Scheuer was there, Peter Scheuer was there. So now they said that another thing that is important is in micronodular, the nodules are uniform. Very important. In macronodular, the nodules are generally not uniform. So as a postgraduate, you must say less than 3 mm with uniform nodules, diffuse uniform nodules. Macronodular are more than 3 mm. Generally, the nodules are not uniform. One will be 4, one will be 6, one will be 8. Here, if it is 2 mm, most of them will be 2 mm. Okay. And mixed, when do you call it mixed? When there is 50-50% of macro and micronodular. Right? So that is important. Micronodular, alcohol, NASH, very important. Macronodular is mainly the post-hepatic ones. Biliary can become micronodular, right? So, yes. Okay. Teres, tell me which of these adipocytes are larger, A or B?
So both are large. Sir.
Which is larger of the two? We have to guess.
B.
Okay. Right. So, one is omental, one is subcutaneous fat. There is a difference in the size of the fat of subcutaneous and omental. There you can get variation in size, right? But general studies have shown that in general, if you take the mesenteric and omental, lot of fat, right? So generally I'm sorry, I mistaken A and B, did like that. The omental and mesenteric fat is larger. Their size are large. They are metabolically different, more active than subcutaneous fat. And all this weight loss and other things, for NASH, it has to aim at reducing the visceral fat, not the subcutaneous fat. And this is an elegant study which shows before and after, the body weight and the amount of visceral fat. Okay. The visceral fat, if it reduces, the NASH also, the grading reduces. It's not important more the weight, but rather the visceral fat. That's very important. What is the normal BMI for Indians? There
18 to
is
25. So
25.
18 to
Bhavya?
25.
Bhavya? Anybody? Anybody in the audience?
No answer, sir.
Okay, you know, in Indians,
18 to 23, sir.
Asians, the amount of fat that is present for the same BMI compared to a Westerner is much more higher. For example, you see in Indians and whites, this green one in males, pale green, turquoise blue color, are the BMI, yellow is fat. You see, this is the Westerner. So in the whites, for the same BMI, you see in Indians and in Chinese and all, the amount of fat that is present for a lower BMI is higher than what in the West. Same, it's much more stark in women than in men. So based on this, now it is well recognized. You know, these are the studies. Well recognized. For Asians, the cutoff is different. It is 23. Okay. Now, for the past 3-4 years, there have been a lot of talks on the nomenclature of non-alcoholic. Telling why call it non-alcoholic? Why non? It has to be something positive. So they came up with this. We'll call it metabolic dysfunction associated steatotic liver disease, MASLD, and MASH, right? So if you have alcohol, you see the changes in both. So you call it MASLD predominant or ALD predominant, and you call it MET ALD, metabolic associated alcoholic liver disease. Okay, so this is the new nomenclature that is coming. Now there's a criticism for the old NASH. It's like non-A, non-B hepatitis. Means you don't know what it is, but you know what it is not. So it is like that. So why have non? It has to be something positive. But now those who are critical of this new nomenclature say, so what? Many things are non-Hodgkin's lymphoma. Yeah. So what is there in that? You are not saying that it's nothing positive, but you call it non-Hodgkin's lymphoma. There are other many diseases with the word non in that. But anyway, most of the associations have agreed to change to this MASLD nomenclature. And so that is what. Somebody has raised a hand. Rose, anything? Okay. So now please remember the criteria. There has to be 1 out of 5. BMA 25 in Westerners, 23 in Asia. Please remember that. Waist circumference 94 in males and 80 in females. Earlier it was 102, but in Indians it is reduced to 90 and 80. Okay. Then the fasting, blood sugar, then triglycerides, blood pressure, HDL and all. So pediatric criteria are similar to that. So this is the new nomenclature. If you want to use, I think Ranjita used this term. So this is what will come. Now 48-year-old male in hepatic coma died after being admitted. Yes, what is it? You only continue, yeah? Tell me. Seeing?
Ballooning degeneration is still.
No, oh, I saw this one's face on the screen, so I thought that he's continuing. Okay, tell me, tell. What it, come on, tell me. Ranjita,
Ballooning,
you're...
ballooning degeneration is there, sir, and
yeah. Rahul, what are you seeing?
microvascular, macro.
Okay, Rahul,
Macrovascular
what?
steatosis.
Huh? You're finding
Macrovascular.
steatosis, macrovascular steatosis. And what are all this? Pink, 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 all around?
Pylori Highland.
Yeah, extensive malarial island. When you get this abundant malarial island, it is never NASH. You'll never get that much malary dengue bodies. Never in NASH will you get that. Right? Please remember that. So this is likely to be alcoholic liver disease. And there is inflammation, right? Fibrosis. So what else? You would like to know the levels of bilirubin, viral markers, serum lipids, anything else? You want to know the history of alcohol intake, no? So that's
EGTs.
yeah. And see, in this there was cholestasis. I don't know if you have noticed. Please remember, if there is cholestasis, no, please mention in the report. We'll come to that why it is important later. Okay. So please remember, these Mallory dengue bodies, they look like this. Alpha trypsin bodies are rounded. This is ground glass hepatocytes. Okay. This is also Mallory dengue bodies, rope-like. Okay. This is our, and this Frank Baum Mallory who described it. View this slide. Anyone? Come on. You're finding this liver biopsy. It looks like cirrhosis, no? See? With fibrosis in between the hepatocytes. There is Mallory's hyaline. Yeah? Yeah? Found
Yes.
this? Abundant Mallory's. Now tell me what is difference between that and this. Anybody from the audience? Anyone? Yes, there is Bhavya.
No
Anybody?
answers.
Huh?
No answers, sir, from the audience.
Azka, Jyotika, no one. See, what is striking between that and this? See this? And now see this. What is striking? There's Mallory's island. Huh?
So one is answered chicken wire fibrosis.
Oh my God. No, anything else? See, this is what happens in pathology. No, oh my God. The main thing. Look at Amitabh Bachchan. You must look at the hero in that. What was the hero in that?
Not there, sir.
Ah. Most obvious thing is steatosis is not there. Looks like alcoholic, but there is no steatosis. So there's only one diagnosis. You have to ask one question. What is that?
Alcohol history.
There's no alcohol history. So why it looks like alcoholic? And it's cirrhotic, in fact. Small nodules. Somebody has written Wilson's.
Wilson's, yes, sir.
Wilson's also has fat. Yeah, tell me. You have to ask the age of the patient. You see this? Cirrhosis. There is abundant copper. Looks like Wilson's, no fat. This is Indian childhood cirrhosis. Right? In Indian childhood cirrhosis, looks like alcoholic liver disease without fat. Remember that. In fact, when from India these slides were taken by Dr. Naik and shown to the pathologists in UK in their meeting, they all called it alcoholic, but without fat. Then he said, these people have never taken alcohol. He told they are lying. And then they said, this is a baby. 3 years old, 2 years old, 4 years old. That's how Indian childhood. But Indian childhood cirrhosis has abundant copper, which is not there in alcoholic liver disease. Okay. Now look at this slide. I'll go through it quickly since it's time. See, look at this. This is a balloon cell, but it's not vacuolated. It's encrusted with cholesterol and this fluffy thing. This is what is feathery degeneration. Feathery degeneration are nothing. They look like balloon cells, but wisps of cytoplasm inside. And there is cholestasis. This is canalicular cholestasis. This is cellular cholestasis. Right? So this is feathery change. This is the ballooning change. There's a difference. You don't have wisps of this, is more like filled with water. And this is another one, but in this, the difference between the others are, it's not that enlarged, but the margins are very crisp. This is glycogen storage disease. So look at the margins. look at the size, look at what is inside. 3 cells look almost alike: ballooning, feathery, and glycogen storage disease. In glycogen, they are called plant-like because the margins are very crisp. Okay, almost like subcutaneous fat, you see. Here the margins are not that one, but in feathery you'll find wisps of cytoplasm. We'll continue. You're finding this cholestasis here. This is the portal tract, canalicular cholestasis, mild inflammation in the portal tract. This is bile infarct. So all this is indicative of a large bile duct obstruction. When you find bile infarcts, they are also called Charcot-Gumbalt necrosis. Okay. The other features in cholestasis that you can get are intraductal cholestasis within ducts. Okay. And this inflammation, this feathery change and all mainly in the periportal areas are because of folate stasis. This color is bilirubinostasis because of the bilirubin. Okay, that's all. The other changes, look at the ducts, there may be inflammation. Okay, and then you can get ductular proliferation and onion skinning. Onion skinning, remember, you get in large bile duct obstruction, not necessarily because of primary sclerosing cholangitis. Okay. Now, how many bile ducts are abnormal? If you get more than 5 in a portal tract profiles, then it is abnormal. The second thing is, look at the bile ducts. If they have a lumen and they are quite regular, then they are called typical or type 1 proliferation. This is because of obstruction or cholestasis. If they don't have lumen, they are misshapen like this. See, no lumen, no cholestasis. Then they are called atypical proliferation or type 2. These may not be seen always in obstruction. This can be seen even in hepatitis. They are the regenerating oval cells of the liver, right? What has happened in this case? So there are two types of bile duct proliferation. Type 1 with the lumen, type 2 without lumen. Type 2 regeneration, type 1 typical of obstruction. Now what is here in this, what is missing in this portal tract? Bile duct is missing. So this is paucity of bile ducts. You get in long-standing obstruction, you get in Alagille syndrome, you get in chronic rejection, and so on and so forth. Count at least 10 to 20 portal tracts, each of them with an artery. If the ratio of portal tracts with arteries and bile ducts is less than 0.5, out of 10, bile ducts are seen in only 4, then it is paucity of bile ducts. You can do a CK19 staining also. View this slide. You're seeing fatty change.
Yes.
You're seeing glycogenated nuclei. You're seeing interphase hepatitis. Is it NASH? Yes or no? Anybody?
No,
See,
sir.
it looks like NASH. Why it is not NASH? You can get Malarizaly. There is this slide,
Ballooning.
abundant copper. This is Wilson's disease. Wilson's disease also can look like NASH. But there's a lot of interphase hepatitis. NASH is mainly centrizonal. This is in zone 1, that is mainly zone 3. You can get glycogenated nuclei, right? And then you're finding a lot of copper. So I've shown you 4 diseases which look almost alike with subtle changes. NASH, or you want to call it metabolic associated steatotic liver disease, alcoholic liver disease, Indian childhood cirrhosis, Wilson's disease. They almost look alike, subtle changes. In Indian childhood cirrhosis, you will not find fat. You'll not find glycogenoted nuclei. You'll not find some interface hepatitis, but you'll find copper. In Wilson's disease, you find fat, glycogenated nuclei, interface hepatitis. Not so much zone 3 changes or centrizonal changes. You can get malaries. In NASH and alcohol, they almost look alike, but in alcohol, you get abundant Mallory xylene, cholestasis, etc. This copper binding. So this is Wilson's disease. Male 28 diabetic, currently presented abdominal pain ascites. Look at this. Inflammation almost looks like cirrhosis. But you see there is cholestasis here, no? See? This. Yeah? Or some brownish pigment is there, even in the bile ducts. Abundant interface hepatitis. Oh, this does not look like bile, it looks like golden yellow and granular. And there is cirrhosis, which is micronodular. Yeah, rounded. This is iron stain. Once again, look at this iron stain. These granules are again in the canalicular pole. What I showed you, no? You see in Wilson's also, it was once again in the canalicular pole. You see this? All along the canalicular, not in the sinusoids. Same, most of these metals, when you see, no, search for them. It's also present in the Kupffer cells, of course, right? Abundant here in the cytoplasm, Kupffer cells. Right? Okay. It is present in the bile ducts. So, what is your diagnosis?
Hemochromatosis.
Hemochromatosis.
Not hemosidrosis. Why? Hemosidrosis mainly in the Kupffer cells and sinusoidal cells. Hemochromatosis, yeah, I agree, it's in this. Is it hereditary or non-hereditary?
For that, we have to do mutational studies.
Kupffer cells, usually that is secondary hemochromatosis. Secondary to any cause.
Is there any, in histology, is there any, yes, Balamitra, you're right, hemosiderin is secondary to transfusion and all, so you get lot in the portal tract, it goes along the sinusoid, so it's taken by Kupffer cells. But you know, in the children, it easily passes off into the hepatocytes, almost looks like hemochromatosis when there is severe hemosidrosis. And hemosidrosis, you have to ask history of transfusion. Somebody wrote a hereditary. Who's that just now? Why are you saying hereditary on this without doing mutation? Balamitra and somebody else. Is there any clue in histology that will suggest it is hereditary? Somebody said no. Sonal?
Sir, yes, sir, they said hereditary, but they have not given the reason for that.
Anybody can give a reason? There is one clue. If the bile duct epithelium contains iron, think of hereditary. So in fact, look at this. Clearly the bile duct epithelium have got. This you will not see in hemosidrosis or hemochromatosis, which is non-hereditary. Generally you don't see. Right? Please remember this. So if you are many places you don't have the facilities, you can suggest, please do genetic studies. It's likely to be a hereditary in nature. Right? Okay. So remember that. Okay. What is this stain? Anybody? Anyway, this is a Van Giesen stain, yeah? The yellow part hasn't come out properly. Okay. In hemochromatosis, the skin turns pigmented, no? Why is it?
Increase melanin.
Yeah, it's not because of the iron. The iron stimulates more of melanin in the basal melanocytes, so that's why you get pigmentation. In fact, there's a beautiful case report of a person with vitiligo. The vitiligo area didn't have pigmentation, whereas the other area had, in a case of hemochromatosis. Okay, now tell me in this, all of you, there is this blue granular. There's one diffuse blue color also. What is that? Is that an artifact? Anybody in the audience? Quick, quick, quick. We have to finish. Anybody? Sonal, nobody's giving answer.
No answers. No answers, sir.
That diffuse blue color is because of ferritin. The granular color is because of hemosiderin. Okay? The diffuse blue color is because of ferritin. Remember that. Okay. Why is it, what is this Prussian blue color? It's in pearl. Why it is called Prussian blue? Teres? Or who is there? Aska? Aska, Jyotika, they're not talking at all. Aska and Jyotika, now you have to tell me why it is called Prussian blue. Aska? She's silent. Jyotika?
Yes, sir.
Jyotika? Okay, anybody in the audience, tell why it is called Prussian blue.
No answers, sir.
Okay. Well, Prussia is, it's not Russia, it's Germany and other areas. A long time. It includes areas from Poland and many other places in the Europe, that area. And Prussian blue is because of the color of the uniform of Prussian army. It was this, they had shades of blue, and this is the usual blue that you get in Prussian blue reaction. So it's the color of the Prussian army, that's why it's called Prussian blue color and pearl stain. Many people call it pearls, Prussian blue stain. The actual term is pearl stain with Prussian blue reaction. Now, somebody asked what is the difference between hemosiderin and lipofuscin. Lipofuscin is smaller, little brownish yellow. Hemosiderin is larger and granular. If you change the focus, it is refractile. And iron stain, that is lipofuscin. Okay. Thalassemia, 1.5 years, blood transfusion, liver function test, HbSAg negative, HCV positive, HCV RNA positive. You see? So it's thalassemia who develop HCV chronic hepatitis. So why did they do a liver biopsy? See, in the liver biopsy, additional information is the amount of iron pigment that you see. See, this is in the cell and in the Kupffer cell, you're finding this. So this is, please remember, if you do diastase pass, sometimes the proteins associated with this or other material can stain. So be careful, you don't overreact. And this is the fibrosis. Okay. So it gives grading, staging, as well as hemosidrosis grading. Now, there are different types. We'll not go into the details of all this. There is no time now. We quickly finish. So please remember, the normal iron in liver is less than 20 micromole per gram of dry weight. Okay. So they calculate an index depending on the patient's age in milligram per gram or patient divided by patient's age, and then they tell this one. If in high power also you don't see granules, then it's grade 0. If you can see it in 10x or naked eye, it's almost, you just then it's grade 4. 25x, it is grade 3. If you see it 100x, it is grade 2, and 250, it is just easily, we can see some granules little bit, then it's grade 1. So that's how. And there are various ways you can grade it and add it. This is a 28-year-old oral contraceptive for 3 years, fatigue, abdominal pain, elevation of transaminases, ascites. Now what are you finding? See these large areas of fibrosis with these dilated vessels, and this looks like portal tract here, no? Bile ducts here. Yeah. Away from the bile duct, this must be the centrizonal or zone 3 area. See, this looks like some bile ducts here. We'll go under hyper. Yeah, this is bile ducts. So this is away from the bile ducts. And look, there are some ductule-like areas here, dilated vascular channels, but they are empty and all the blood is here. Okay, look at this. Some ductule-like transformation, sinusoids, and these RBCs here. These are the surviving hepatocytes, centrizonal area. All the RBCs are here, sinusoids are empty, fibrosis extensive, and some ductule-like areas here. But they are in the centrizonal area. Right? See this. Extensive fibrosis, there is cirrhosis, zone 3, and these portal areas. So this centrizonal thing, see? Almost you can see the space of Dissay is all fibrous. These hepatocytes are here. These sinusoids are dilated, mainly in the centrizonal area. So what other investigation? This is hepatic venous outflow tract obstruction. So you will require a radiology. And please notice that in all these, sometimes the hepatic trabeculae are replaced by RBCs, sinusoids are empty. This is called red cell trabecular lesion. This is a portal tract. These are hepatocytes. This is the centrizonal area. Red cell trabecular lesion is typical of venous outflow. This can be seen either the hepatic vein is blocked or there is increase in right ventricular pressure as you get in congestive heart failure. Please remember, you can get similar features, but such extensive features are seen in hepatic venous outflow tract. View this slide, look at this. The only difference is here there is necrosis, hemorrhage, but it looks sharply demarcated. The portal tracts are absolutely empty. You see this? This you can get in shock. Any other condition? I told you right in the beginning where you can get necrosis which is sharply demarcated. Anybody? Do you recall?
Drug induced, sir.
Drug induced or toxic. Excellent. That's what you should think of. Hepatic venous, shock, acute right heart failure, or toxic. Very good. You give this 3 differential diagnoses, the clinician will work. Please remember, often you need not give the exact diagnosis. You narrow down the differential for the clinician, it will help you. Okay. Now see this portal hypertension looks almost normal, but no cirrhosis. But you see the hepatic veins slightly large here, it becomes slightly fibrosed here, and here you're finding some dilated sinusoids. Some sinusoid, you see, dilated, mishappen all of a sudden. See, all this, and fibrosis here. See here, very little. There's no there's hardly little bit of inflammation. So this is when you don't find cirrhosis, slight portal fibrosis, the non-cirrhotic portal fibrosis. Next, you see here, I told you, whenever you find hepatocytes, which looks almost slightly, the cytoplasm looks as if it's painted slightly. Eosinophilic, do HBsAg. We did, and it was hepatitis B positive. This is a 14-week old cirrhosis, and see this almost onion skin like fibrosis. I told you this is typical of biliary obstruction. This is a 14-week old with cirrhosis due to biliary obstruction. What do you think the diagnosis will be? Which biliary obstruction is common in which you get cirrhosis within, say, 12 weeks? It's biliary
cholecystitis.
Yeah, extrahepatic biliary atresia. Please remember, you have to diagnose that very fast. Within 12 weeks, if you don't do anything, the children go into fibrosis. See, this is typical of biliary cirrhosis. I told you you'll get nodules and you'll get this parallel, fibrosis in any biliary obstruction. And this cholestasis. Okay. Look at that. Okay, now quickly we'll go to these cases. What are you finding? This inflammation near the portal tract, extensive necrosis. Look at this. Looks like necrosis. Full. The entire lobule has gone. Look at this. So many portal tracts together. What kind of necrosis is this called? This called panlobular.
Globular.
Okay, we are revising it. These are all revision cases. Okay, so you see this, and you're finding bile ducts here, right? These are the type 2 bile ducts, They try to regenerate. There's some inflammation. It's all necrosis. Diastase passes the spheroid-laden macrophages, indicating there was necrosis there. This is collapse, right? In the reticulin stain. This is not fibrosis. Okay. Surface antigen, core antigen negative. We don't know why the core antigen is negative. If surface antigen is negative, it has to be acute. Told that. Second case, you see this? Again, this is portal based inflammation. This doesn't look necrotic. Okay, there's a lot of inflammation here in the portal tract interface hepatitis. You're seeing this? It's going on. Oh, good Lord, look at this. This is a bile duct with inflammation here. And look at these cells. They don't look like the usual lymphocytes, histiocytes. Look at this here. Look at this. What is this likely to be? Yeah, it looks like a granuloma, no? Look at this. Yeah? Here you might be confused whether it's hepatocytes or not. But look at the nucleus. If the nucleus is slightly elongated, slipper shaped, it's likely to be a granuloma, Okay. Let's look at this. These are granulomatous inflammation in the liver. You see, this is a granuloma, mainly portal base, next to the bile duct. You see, this is a bile duct next to the bile duct, the interface hepatitis. What do you think this is likely to be?
Biliary cholangitis.
Yeah. Primary biliary cholangitis. Yeah, very good. You have to think of that. Look, this is copper stain. So when there's bile duct obstruction, copper is increased. You have to do anti-mitochondrial antibody, or these plasma cells will be IgM. Okay, look at this. Now, look at this cell, this one, 2 cores of liver tissue. Again, look at this. You are again finding a granuloma here. This looks like necrotic area. Look, this is a granuloma with giant cells. Okay, Langerhans type here. There's some inflammation. So what do you think this is?
Sarcoidosis.
Huh? Sarcoidosis. The other diagnosis will be tuberculosis. Sarcoidosis. See, sarcoidosis is little rare, and of course tuberculosis also you can get. They look alike. The difference is in tuberculosis generally you get a lymphocytic cough. Whereas in sarcoidosis, the granulomas don't have that much lymphocytes. It's called a naked granuloma. And secondly, you see in this, there was this area which looks somewhat necrotic, this one. So it might be tuberculosis, but it's good. Sarcoidosis versus tuberculosis is always a differential diagnosis. You are right, there's not much of lymphocytes, although there are some. So that it's not naked. So you have to ask them serum ACE levels, look at the chest X-ray and find out what it is. And what can you do?
Reticulin, sir. Reticulins.
Okay, reticulin is this.
AFP.
This is little poor here. Here it is rich in reticulin. In sarcoidosis is rich in reticulin, whereas tuberculosis because of necrosis becomes little poor. So it doesn't help. So what else can you do? Do an AF. CD34. Somebody has said, yeah, you can do CD4 stain, CD8, but you can do a AFB stain. Fortunately, in this, there was one AF. So this was actually a case of tuberculosis. What is this granuloma? Anybody? You get it in the liver, you can get it in. This is a fibrin ring granuloma. Vanessa Sebastian is right. Fibrin ring granuloma, see this fibrinous, this pink material is fibrin. They are all histiocytes, predominantly histiocytes with a ring of fibrin, some neutrophils you can get, and very little lymphocytes. You can get, it was identified earlier in Q fever, Coxiella burnetii. You can get in various other conditions. And nowadays we see it even in immune checkpoint inhibitors, the ipilimumab and nivolumab. So these are the drugs in which you can get in allopurinol, Hodgkin's disease, hepatitis A, Epstein-Barr, fibrin ring. What is this granuloma? I showed you one. Anybody? Yes, this is a lipogranuloma, oleogranuloma. If you find an oleogranuloma in the portal tract, think of ingestion of mineral oil. They take it as laxative and all that, no? Mineral oil, when they take, it's taken up, and then you can get these oleogranulomas in the portal tract. So that's why I'm showing. Okay? But here, this you can get in NASH, in obesity, diabetes, and so on. Now, this is one case. Look at this. Looks like cirrhosis, fatty change, bile duct proliferation. What are this? What is it? Huh? These are what are, yeah, these are Mallory Denk bodies. What do you think it is likely to be? So many Mallory Denk. Yeah. What is it likely to be? Alcohol. Yeah. You're likely to be alcohol. This is a megamitochondria there for you. Okay. And there's fibrosis, chicken wire, fatty chain. And look, there is cholestasis. If there is cholestasis, please write it in your report. See, cholestasis. Very important. Why it is important, we'll come to it. And look, this is all the usual bile ducts. They are all mainly the typical bile ducts that have proliferated, like in cholestasis. These are the type 2 ones, atypical ones, trying to regenerate. Usually, we can't predict, but this is what they say, that these are the oval cells. So chicken wire. The reason is there is a alcoholic hepatitis, this score is there. So what they add in this AHHS score is they add the fibrosis, okay, 0 to 3, bilirubinostasis, which I showed you, none, canalicular or ductal canalicular, it is 1 plus, megamitochondria, 2 plus or present, whatever, polymorph, how much there is, and you add all the points. And this is the 90-day mortality. So in an alcoholic liver disease, please look for fibrosis, look for cholestasis, megamitochondria, and polymorphs in addition. So this is the message. Finally, look at this. This is another one full of inflammation. And we are finding, what are these cells? Yes, Bhavya. Last case, tell me, what are these cells?
Hepatic rosets.
Huh? What are they? Anybody?
Rosets.
Huh? What? What did she say?
Hepatic rosets.
Hepatic rosettes. No. Hepatic rosettes is many hepatocytes together. This is individual cells
Giants.
which are large, multiple.
Multinucleated.
With
Yeah,
two-tone
yeah.
giant cell. Venice.
They almost look like, some look like two-tone. You look at this. Giant cell, 1, 2, 3, 4, 5 nuclei.
So are there.
1, 2, 3. This is giant cell hepatitis. This is a canalicular rosette. See, look, canaliculus. 1, 2, 3, 4 hepatocytes. Where the small canaliculus without bile. So this is a canalicular rosette. Hepatic rosette must be like this without the canaliculus. Okay. And these are giant cell, large ones. Okay, here we have done 2 stains. Look, BSEP, bile salt excretory protein, which stains the canaliculi, and the MDR3, multi-drug resistant gene 3. This also you see faintly staining the canaliculi. The reason why we do these stains in neonatal hepatitis is sometimes there is progressive familial intrahepatic cholestasis. And there are different types, type 1, 2, and 3, and so on and so forth. Need not know this. In these excretory proteins, and this will be in different types, they will be mutated. Once they are mutated, these canaliculi won't be stained. So that is why we do it. Right? So this is the fibrosis. So we end. Thank you. This is a marathon session of 2 days, and I don't know how many, 6 hours of liver biopsy. Still, so I've tried to tell you something new, something that. Please remember, I've taught you some of the older things also. It's necessary when you're learning as a postgraduate, but things are changing. See, this is from, I think Denver, one of the places in US. I just put it up to show you between 2007 and 2008 and 17 and 18 recently, what are the methods by which they are doing liver biopsy. Earlier, it was percutaneous liver biopsy or CT guided or image guided liver biopsies. In 2017 to 18, gradually, so you see the more of transjugular liver biopsies and EUS liver biopsies. They put in an endoscopic ultrasound guided endoscope through this stomach. They'll put into the liver and take a liver biopsy like they're doing EUS for pancreatic and other lesions. Okay, they can do. So from percutaneous, it's being shifting to EUS guided, ultrasound guided. Here we are currently in this stage, mainly transjugular and some ultrasound guided, rather than blind percutaneous biopsies. They're becoming less. Then in changing indications. Earlier, see chronic hepatitis B, 2008. This is a Korean study, but it's almost same everywhere. 2008 to 12. A lot of hepatitis B, now it has decreased. Hepatitis C, now it has decreased. What has increased is NASH. You see, NAFLD, fatty liver, it has increased. Autoimmune hepatitis, it has increased. You see, alcoholic liver disease, it has increased. Autoimmune, it has. So nowadays, most of the biopsies are done for autoimmune, alcohol, NAFLD. That's why I gave almost two cases of each, so that your PBC, this and that, some idea you have, and you learn. The rest, please look at chronic hepatitis, look at other lesions, liver biopsies. And hopefully you'll go back with a new outlook on liver biopsies. Thank you. This is St. John's and this is the institute where I live. Case 6 posted in the Telegram group. Wait, let me see. What was case 6? Case 6. Sonal, can you tell me the history?
Sir, I'll see him.
Huh?
Sir, I'm looking for it.
Anybody of the children, anything you want to know from me? On liver biopsy, I'm sorry, I can't give you dinner. I would have if you were near my house.
Sir, clinical history was male 32-year-old, presented with recent onset of fatigue and fever, mild elevation of transaminases, raised alkaline phosphatase, and ascites detected clinically.
6. Okay. Let me see.
Sir, that case 6 is the granuloma one, sir.
Granuloma, yes, sir.
Oh, granuloma one. Revision one, which one? Case 5, venous outflow.
J.
I sent you 5 cases, no?
No, sir, you
This
said
is
6.
one. There is a
6.
granuloma there.
Last one was the granuloma.
Tuberculosis one. Or the AIH one.
AH was second case, sir, that you discussed previous week.
This one, sir.
One?
Yes, sir.
Yes, sir, this one.
This is the tuberculosis one, yeah?
Yes, sir.
Okay. No, wait. I'll find out. Acha, which book do you read? There are many books you can read. See, there are small books. One is Liver Biopsy by Peter Shaya. He is no more. I worked under him. He is no more. So J. Lefkovich is the editor of that. He does it. So you can read that. There is one by Sanjay Kakkad and others. That's also a good book you can read. And the bigger book is Max Sween's Liver Pathology. That's a thicker book you can read. There are several other, small gastroenterology, nephrology, pathology books like those by Odzi and others. They also have chapters on liver biopsies. So these are the ones. And the best books, of course, are by looking at the slides. And many of these things, you learn by experience. Somebody teaches small things, like if you find in the bile ducts, pearl stain, think of this. If you are finding this, you think of that, and so on and so forth. So these are the other things that I would suggest that you do. Any other, let me see, webinar, what are the cases I sent? Cases for students. 1, 2, 3, 4 HP to 6. 6 is the tuberculosis, in which AFB was positive. 6 was tuberculosis. Okay. Anything else? Residents, so y'all did well, and I'm quite pleased. Please show normal reticular pattern. Normal reticular pattern, I think I showed here. Oh, I showed after this. Yeah. Dr. Bhavita, the normal reticular pattern is what you see here, is the entire thing. The abnormal pattern is here where it is parallel. This is normal here. This is normal. Forget about this side. These are all normal patterns. When it becomes linear, it becomes abnormal. There were many of these. There's not time. You see, if you see this, you see, here it has become linear. This is abnormal. This is normal. Hope you are understanding this. You see this? Isn't it becoming parallel and linear here? This is abnormal. You see, this is the normal pattern. This irregular. Here you see it is again becoming linear. When you see a reticulin stain next time, please look at all these things very carefully. It's quite fun, you know. A lot of things that one can understand from all this. We often don't see it that critically. Anybody else?
Sir, Vanessa Sebastian is asking why not parallel normally. The reason for that.
Normal. I see if it is parallel normally, the blood will just flow, no? It has to go like a maze. Then only it will go slowly. Then you see if something is coated by antibodies, the Kupffer cells will see, it will recognize the FC receptors of these antibodies which are there. Then it will engulf them. That is why in typhoid, you know, the RBCs get coated by antibodies. The FC receptors are recognized by the sinusoidal cells. They engulf. So you get sinusoidal engulfment of RBCs. So inside the sinusoidal cells, if you get that in septicemia, you get it in typhoid fever. That then you know there are so many other things. Old RBCs when they're flowing through the liver, even spleen, it is sinusoid. So then when it goes like that, the spleens also, all the littoral cells, they engulf them. The blood flows slowly, then there is exchange. There are a lot of things that are going on. That's why. Yes, somebody asked, what is the, normally are they encircled by reticulin? You know, the reticulin is deposited, the stains part of the space of disease. So wherever it is there, it will stain like that. And there is no basement membrane as such, which these reticulin fibers stain. So you get it deposited around that. It's not exactly in the cell. It's just below the endothelium. There, the reticulin fibers are there a little bit, so they get deposited. Then it will not be a continuous line. There may be a little gap there if you see under very high power. So that's how it is. Any other question?
No more questions, sir.
Thank you. It's been quite long, and I think I'm sorry to have kept you all away from your.
No, sir, it was a very informative and lucid lecture, sir. Thank you so much for that. Everyone has benefited from this. So thank you so much, sir, once again.
How many
Sir,
people
still there are 58
Oh
participants.
my God. My apologies to all of them for keeping
No,
them
sir,
away
it was
from
very informative.
their dinner. And I'm sorry, those of you who are celebrating today, I'm so sorry that your good dinner is awaiting you. Your family must be awaiting you. And
No, sir, your lecture was like a feast to us. So we got a lot of information. So thank you so much, sir, once
Not
again.
at all. I hope all of you go back and